sweetie, I got enough to feed the needy. No need to be greedy. I got mad friends with Benzes. See notes by the layers. True to life players. Jump in the Rover and come over. Tell your friends jump in the GS3. I got the...
Good morning, all New York City. Welcome, everybody. What a thrill for you to be joining us. My name is Sally Bogosh, and I am an assistant program director at Maimonides Medical Center in Brooklyn, New York. I'm also a really proud board member of the All New York City Emergency Medicine Group, where our mission is to collaborate to bring innovative emergency medicine education to our regional EM community. Thank you so much for a super hardworking group of people who put this conference together. A lot of work went into producing this event, from behind the scenes, ideas and inspiration, to graphic design, and of course, tech. We certainly don't want to take away from the extraordinary talent of our speakers today. But just a quick word about who we are. Who are we? Well, this is us. We have these participating residencies from the 5 boroughs, Long Island, upstate New York. And we're just so grateful that everybody has been able to join us today. All right, so it has been quite an extraordinary year, and we certainly hope that we can all be in the same room together next time so we can get back to our live concerts, conferences. But until then, I welcome you to sit back in your pajamas, enjoy the show, and please join me in taking a shot every single time a panelist says, "Can you see my screen?" This morning I'm sticking to coffee and seltzer, but you do you. And without further ado, I invite the spectacular Dr. Jenny Beck-Esme to welcome our first speaker.
Thank you, Dr. Bogoch. You have put so much work into this, and I think it's going to really be a great conference today. I'm very excited to be welcoming our first speaker, Dr. Susan Wilcox. She's the Chief of the Division of Critical Care, as well as the Vice Chair for Clinical Affairs within the Department of Emergency Medicine at Massachusetts General Hospital. She has special interests in mechanical ventilation, pulmonary hypertension, and critical care transport. But today, she's going to be sharing her expertise with us on her approach to cardiogenic shock. Dr. Wilcox.
Hi, everyone. Thank you so much for having me. I'm really honored to be here. All right. So since I know I'm not supposed to ask, I'll just assume. All right. So as you heard, I'm going to be talking about cardiogenic shock. I have no disclosures. So the first thing I want to start with is describe what is cardiogenic shock. What am I saying when I'm talking about cardiogenic shock? I want to emphasize that we see a lot of heart failure in the emergency department. And heart failure really means that we have a patient who's got ineffective cardiac function for whatever reason. In many instances, it's because they have a decrease in their contractile function, but it can be due to diastolic dysfunction, valvular disease, a whole host of different things. But when we have heart failure that transitions into the patient not receiving enough oxygen to their peripheral tissues, that's shock. And I think it's really important in the emergency department that when we have a patient who has shock from cardiac dysfunction, we label it as such, because it's so critical that we understand what we're dealing with, because calling cardiogenic shock heart failure, it undermines the importance of the issue. Cardiogenic shock is not a common cause of shock in the emergency department. This graphics are based upon data that I took from a European emergency medicine study. And I think that it probably overrepresents the amount of cardiogenic shock that we see in our emergency departments. It's actually very rare that we see cardiogenic shock in the ED. However, it has an extremely high mortality rate, even in this day and age. The mortality rate for cardiogenic shock is somewhere in the 40 to 60% range, depending upon etiology, comorbidity, and such. And so it's so critical that we label it as cardiogenic shock, recognize what we're dealing with, and intervene appropriately. Lots of different things can cause cardiogenic shock. The most important one for us to know in the emergency department is, of course, ischemic causes. This is the most common cause, and it's the most critical one for us to intervene upon. So this can be STEMIs, but it can also happen with patients who are having non-STEMIs. Other things to think about are the post-MI complications, which thankfully don't occur that much anymore due to common cardiology practices, thankfully, but they do present to the emergency department on occasion. Patients who come in, had a STEMI, and then 48 hours to even a week later, they come back with their mechanical complication. A more common cause of cardiogenic shock in the ED is actually the patient who has chronic cardiomyopathy. And it's that patient who's been kind of going along okay, and then something tips them over. And their causes of cardiomyopathy can be due to ischemic disease, say like they had an MI years ago, or idiopathic cardiomyopathies, previous viral cardiomyopathies, all sorts of different things can cause it. But yes, something usually tips them over, and then they come into the emergency department in shock. Stress cardiomyopathy is also known as Takotsubo's. It's not an infrequent cause of cardiogenic shock in the ED. Myocarditis, again, we've been thinking about that a lot over the last year. It's certainly been something that's at the forefront of our minds with COVID, but other things besides viral myocarditis can cause myocarditis, and it does cause cardiogenic shock. Patients with valvular disease can be kind of like the patients with chronic cardiomyopathy. They can be going along okay, and then something tips them over. And I keep emphasizing the something because it's often arrhythmias. Arrhythmias are very unlikely to be a primary cause of cardiomyopathy in a patient who's got an otherwise normal heart. However, they can be the thing that tips these patients over or exacerbates the cardiogenic shock from all of these other different etiologies. So arrhythmias are still very important in the management of cardiogenic shock patients. And over to the side, you see I've got here left ventricle, right ventricle, and biventricular failure. So this is important, and I know you're about to get a talk on right ventricular failure in and of itself, so I'm not going to belabor that too much. But it is helpful to think, are we having a right-sided problem, a left-sided problem, or a biventricular problem? Because we've for so long thought about the heart as just really being the left ventricle, and it's not. And so having an idea of where the problem lies helps us manage the patient more effectively. Cardiogenic shock is not always easy to recognize. Now, when a patient comes in with a history of like chest pain, shortness of breath, clutching their chest, and they're in extremis, those are pretty easy to recognize. But unfortunately, I guess maybe fortunately for the patients, unfortunately for us, patients don't always present with such a clear-cut presentation. And so they might come in and they're just feeling unwell, but they're cold, they're clamped down, they're mottled. And I have a picture here of a young man who had viral myocarditis from flu B, and you can see his foot. It's blue, it's purple, it's clearly being poorly perfused. We've got a bear hugger on trying to keep him warm. And sometimes people blame my beloved pressors for this. This patient was not on pressors. This is not due to pressors. This is the patient's intrinsic compensatory mechanism for trying to maintain his cardiac output. And so he squeezes down, his blood vessels squeeze down to try to maintain the blood pressure and maintain his cardiac output. And another way this manifests is low pulse pressure or a narrow pulse pressure. You can see that image that I have there of a patient's screen in the CCU, 82/72. That's a very narrow pulse pressure. Sometimes it's not quite so obvious, but when you see that, that's an indicator that there could be a cardiogenic cause of shock. If a patient comes in and they're in shock and they have an elevated JVP or pulmonary edema, that's also a nice marker that this could be cardiogenic in nature. And an important thing to remember in cardiogenic shock is that the patient's not always hypotensive. So, we often think about shock equals hypotension, but not always. Remember, it's ineffective oxygen delivery, ineffective blood flow. And so if the patient's not getting enough blood flow because they're clamped down, their blood pressure might be okay for a while, but they're still in shock. If a patient has EKG changes, they have a STEMI, their extremis, these again are very easy patients to recognize, but their EKG changes might be more subtle. And that's why it's important for us to keep cardiogenic shock at the forefront of our minds when we're examining these patients. And this is the EKG for the young man whose foot I showed you, the viral myocarditis. I know no one would have any problem recognizing that this person is in cardiogenic shock. This is easy, but again, they're not always so straightforward. This is where ultrasound comes in. I'm speaking to a group of emergency physicians, and this has really become our wheelhouse. We are experts at the bedside cardiac ultrasound, and it's such an invaluable skill in examining these patients. Not only does it help us point towards cardiogenic causes as opposed to distributive or other causes of shock, but when I was talking before about left and right ventricle, it helps us actually start to delineate which side is the problem, or if both are the problem. So when you see an image like this patient with these massive atria, it kind of tells you that there's something chronic going on, and this can be an important clue to what's causing the patient's cardiogenic shock. I could do a whole hour talking about the pros and cons of different methods of assessing volume responsiveness, if we should actually be using the term volume tolerance, which is a term that I really like, talking about the limitations and the benefits of ultrasound for this, because there's a lot of data, a lot of thoughts, and I only have a couple minutes. What I'll say is that I look at it as a data point. There are some significant limitations, but if we have a patient who's in shock and we look and we see a plethoric IVC, that at least is a data point. It helps us get a little bit of a sense of what's going on. And so it's not the end all be all for determining volume responsiveness in all scenarios. And so I'm not trying to make that argument, but again, I encourage people to look at it because it is a data point, and taken in context, it can be helpful. Once we've determined that the patient's in cardiogenic shock, it's really helpful to determine if they are having an ischemic cause. And so looking at the EKG, thinking about ischemia as an etiology is so critical, because this is where, as emergency physicians, we have to intervene. So I have my cartoon here of the heart, and I have this, LAD having a lesion here. This illustrates why it's so critical. So this LAD has a lesion, and we have decreased blood flow. Makes sense? We start to get an area of ischemia, and the next thing that happens is we start to lose cardiac output. Now, these arrows represent what we would expect for normal contractility. The black arrows are showing normal contractility, and the red arrows are showing us normal cardiac output. But in the setting of ischemia, now we have decreased contractility, decreased cardiac output. That's all intuitive. But the thing that people sometimes forget about is that if the blood's not going out, it's got to be somewhere. And so it's often just sitting there in the ventricle. And what that means is it's increasing the wall tension inside that ventricle. So now you've got two additional problems. You already had a lesion there in the coronary artery, so you have decreased blood flow. Now you've got decreased cardiac output because you're not putting as much blood down through that already narrowed or completely occluded, that's a problem, artery. But then also, if you've got that increased wall tension, you can imagine that's going to further decrease any blood flow as you've got the increased wall tension. And so other collateralization is going to be minimized, and it's just going to be creating a downward spiral. And that's why it's so critical that we intervene as soon as possible. And we aren't doing the cardiac catheterizations, but it's our job to recognize these patients and get them where they need to be. So we want to open up that blood vessel, minimize that ischemic time, and try to restore their normal cardiac output. It's the most important thing we can do when a patient presents with cardiogenic shock due to ischemia. And so when we think about the rest of managing these patients with cardiogenic shock, we always talk about airway, breathing, and circulation as our resuscitative goals. And in cardiogenic shock, I really argue that it's better to think about preload, contractility, and afterload. So when we're thinking about preload, unless the patient is grossly volume overloaded, the American Heart Association recommends starting with small boluses. Now, if that patient is a chronic cardiac patient, a chronic cardiomyopathy, they might well be volume overloaded. But if they're not, it's reasonable to start with a small bolus. But remember, if they are one of those patients, they might benefit from diuresis. So I have this X-ray here showing, this is a patient that I have in the CCU who has a lot going on. This is a patient who needs diuresis, not more volume. We want to move very quickly to vasopressors and inotropes. And I would also encourage you, just like using heart failure and cardiogenic shock appropriately, if you can use vasopressors and inotropes appropriately, it adds a level of sophistication to your discussion about managing these patients. So the drugs that we're going to use for cardiogenic shock are, thankfully, ones that we use all the time. Norepinephrine is our first line agent. We're all very comfortable with norepinephrine. We know how to use it. That's the good news. Vasopressin can be very useful. If a patient is really tachycardic or they're in that vasoplegic stage, they've gone from their squeeze down and now they're starting to vasodilate, vasopressin can be helpful. It doesn't act on the pulmonary vasculature, so that can make it useful in the settings of biventricular failure or right ventricular failure. Now, dobutamine is a drug that we don't use very much. And I think part of the concern is that dobutamine is a vasodilator. Dobutamine causes a decrease in your systemic vascular resistance while it increases contractility. And so we don't use it as much in the emergency department, but I do think in these particular patients, there's a role for dobutamine. Epinephrine used to be one of the first line agents, but there have been some recent studies that indicate that epinephrine may be associated with some worse outcomes in patients who have cardiogenic shock. And so it's really fallen from being a frontline agent more to a later, like a second, third, or fourth line agent in cardiogenic shock. So putting this all together, here's my algorithm for managing cardiogenic shock with regards to vasopressors and inotropes. Cardiogenic shock patient who's hypotensive, start with norepinephrine. If they're vasoplegic or very tachycardic, you can start with vasopressin. If you've given them norepinephrine and they're hypotensive or they're getting too tachycardic, then you go on to add vasopressin. If they have poor perfusion, they're in that clamp down phase, but they're not yet hypotensive, then you can start with dobutamine. And if you've given them norepinephrine, vasopressin, and they're still poorly perfused, think about that foot I showed you, they're cold and clammy, then you can add dobutamine on top of it. But dobutamine can cause hypotension. So if they start to get hypotensive, go back up to the top and increase your norepinephrine or add the norepinephrine if you didn't already have it on board. If the patient has bradycardia, they have one of those arrhythmias that's then causing them to tip over. So if they have bradycardia causing shock, in that case, it's probably reasonable to start with epinephrine as your first line agent. But otherwise, I would recommend that you go through the rest of this algorithm. And if the patient's still hypotensive or hypoperfused, then it's appropriate to add epinephrine at that point. The last thing I want to talk about is afterload. And the major cause of afterload that we have in the emergency department is positive pressure ventilation. And again, I'm not going to belabor the right heart too much, but it's helpful to think about the right heart and the left heart as being different because they have different responses to positive pressure ventilation. The right ventricle doesn't really love positive pressure ventilation in many instances. It does decrease preload, and I have that illustrated here by the blue and white arrowheads. You can imagine that positive pressure inside the chest is going to decrease the venous return from the SVC and the IVC. But the other thing that it does is look at that little inset that's supposed to be alveoli being all distended by the positive pressure. And you can imagine that crimping little arterioles throughout the pulmonary vasculature. All of that crimped, increased pulmonary vascular resistance is going to lead to an increase in afterload on the right ventricle. Now, conversely, the left ventricle is going to have a decrease in preload because you have a decrease on the right side. You're going to have a decrease on how much blood flow is getting over to the left side. So you have a decrease in preload on the left side, which often it likes because often the patients are volume overloaded. But it also decreases afterload. And this is a key distinction. Positive pressure decreases afterload on the left side. And what it does is it decreases that transmural pressure. And I have that illustrated there between the red arrows and the black arrows. The black arrows being the positive pressure in this situation. So you can imagine it decreases the transmural pressure, decreases afterload, and the left ventricle in general usually likes that. If you're doing all of these things and the patient's not getting better, you probably need to be thinking about mechanical circulatory support. The intra-aortic balloon pump is really falling out of favor. It doesn't offer a whole lot. The studies haven't shown a lot of benefit. Impellas, we've got them there in the middle. We use them a lot at my center. Unfortunately, they just don't do quite as much as we want them to, but there's probably a patient population that will benefit. And then ECMO is ever growing. We have a patient here who's peripherally cannulated for VA ECMO. If you are at a center that does not do mechanical circulatory support and you have a deteriorating cardiogenic shock patient, be thinking about how you're going to get them to a center that does offer MCS, because this is the next step for that patient who's not responding to your appropriate medical therapies. And so to end this up, I'm just going to put it all together in a little algorithm here. The most important thing we have to do with cardiogenic shock is recognize the problem. We have to recognize what we're dealing with, and it can be challenging in the emergency department. And so I advocate optimizing their preload. Think about them being volume responsive, recognizing limitations therein. Small boluses may be indicated, but they also might need diuresis, which is why determining their volume status can be so challenging, but also so important. Contractility, we need to reperfuse the patients who need reperfusion. That's one of the most important things that we do in the emergency department, recognizing these patients and getting them to the appropriate care. Use norepinephrine if they're hypotensive, vasopressin, dobutamine, and then epinephrine is what I recommend for your algorithm for supporting their blood pressure. And then for afterload, remember that positive pressure ventilation will decrease their left ventricular afterload. They like that, but it can increase it on the right side. And the vasodilation may be helpful if the patient's not hypotensive, like using the dobutamine. We can start with that as our first line agent. So with that, I will stop there. Thank you all so much for your attention. I really appreciate it.
Wow, Dr. Wilcox, thank you so much for that spectacular approach to acute cardiogenic shock. It's incredible how you broke that down to be so manageable, such a nuanced topic. Really amazing. Thank you. Great start to our Springtime All New York City conference. Next up, I'd like to welcome the extraordinary Dr. Eitan Dickman. Dr. Eitan Dickman trained in New York City. He is an NYU graduate, continued through his training at Jacobi, where he graduated from the EM residency program, and self-describes as an ultrasound zealot. He was one of the first ultrasound fellows at Christiana Healthcare. And it turns out that he has sort of shifted into more of an operational and leadership role. He currently is the executive vice chairman at Maimonides Medical Center in Brooklyn, New York. I refer to him very affectionately as my boss. And today he's going to get back to his ultrasound roots and talk to us about the ultrasound approach to the dyspneic patient. Thanks so much, Dr. Dickman.
Good morning. Thanks for the introduction, Sally. We're going to be speaking today about the sonographic approach to the acutely dyspneic patient. And there's a lot of material here to cover, so let's dive right in. As a bit of background, I suppose the question is why speak about this topic? We all know, we work in the emergency department, we know that shortness of breath is a very common chief complaint. It turns out that almost 8% of all ED visits are related to shortness of breath. This translates into millions and millions of visits across the country. And as our population in this country ages, and we look at the most common reasons for admission for the 65 to 84-year-old age group, we can see that in those who are coming in due to CHF, pneumonia, and COPD, shortness of breath is going to be a very common reason for their admission. But in addition, those patients who are admitted due to sepsis and dysrhythmia oftentimes will also have shortness of breath as a key component. And so we see that shortness of breath ends up leading people to come to the ED, and it's also a common reason for patients to require admission to the hospital. Now, over the last 10 to 20 years, there's been a significant change in hospital culture. In the past, the emergency physician was charged with resuscitating patients, stabilizing the patient, and ensuring a safe disposition. Admit versus discharge, admit to the floor versus admit to the ICU. However, I'd say within the past 10 years or so, there's been a real culture change, and it is now the emergency physician is expected to be the primary diagnostician for the hospital. And there's a real implication. We want to make sure that we're accurately diagnosing our patients. And the days of admitting undifferentiated abdominal pain or undifferentiated shortness of breath to the hospital is really falling by the wayside. And so the diagnosis attributed by the emergency physician has significant implications for patients being admitted. This was demonstrated very nicely in a study that was published a few years ago, in which they looked at over 500 elderly patients who came in due to shortness of breath and were found to be in acute respiratory failure. Now, in 80% of cases, there was concordance between the ED diagnosis and the ultimate hospital discharge diagnosis. The corollary of that, of course, is that in 20% of the cases, there was a discrepancy and the ED diagnosis was felt to be inaccurate. And when you looked at the two groups, there was a significant difference in hospital length of stay, but more importantly, there was a significant difference in mortality rates. So the diagnosis we come up with in the ED really has significant implications. Now, 20, 30 years ago, when point of care ultrasound was first introduced to the ED, everyone was very excited about the FAST exam and the ability to detect internal hemorrhage. I would actually argue that as the population ages and as we're seeing more and more patients present with shortness of breath, thoracic sonography is actually the most important diagnostic application that we utilize on a regular basis in the ED. Let me illustrate that with a case. So this was a 78-year-old male, history of diabetes, hypertension, CHF, and COPD, who presented with acute shortness of breath. He was somewhat tachycardic, tachypnic, as well as hypoxic. And due to body habitus, lung exam was somewhat limited. So in the past, maybe a shotgun approach would have been employed, treating the patient for both CHF and COPD. Maybe they would have been waiting for a chest x-ray, BNP, other test results. However, nowadays, shortly after arrival, the probe is placed on the patient, and very rapidly we can see B-lines, diffuse B-lines. And if this image was also obtained from the other side of the chest, we know that we're dealing with acute pulmonary edema, and we can initiate treatment in a rapid manner. Because this looks significantly different than A-lines, here we see the pleural line between the rib and shadow, and we have these recurring reverberation artifacts, which are known as A-lines. And Daniel Lichtenstein, who's really the father of pulmonary ultrasound, showed years ago in his study that diffuse bilateral B-lines was seen in 100% of patients with acute pulmonary edema, whereas those whose respiratory compromise was due to acute COPD or asthma exacerbations had bilateral A-lines. And one of the conclusions of his study was that respiratory distress without evidence of B-lines effectively rules out pulmonary edema as the etiology of the patient's respiratory distress. So one of the takeaways is you need to be able to rapidly and accurately differentiate A lines from B lines. Next case, 87-year-old female with a history of diabetes, CHF, and hypertension who presents with shortness of breath after recent hip surgery. She was tachycardic, somewhat tachypnic, and hypoxic. Now, in this case, the diagnosis was fairly straightforward. In this apical four-chamber view, we can actually see thrombus on the right side of the heart. This is a clot in transit, and so we know that pulmonary embolism was the cause of her hypoxia. And the question often comes up is, how good is point of care ultrasound for the diagnosis of pulmonary embolism? And the answer is, it depends. For small subsegmental PEs, it's actually not a great test. However, as the PE becomes larger, there's increasing clot burden, and there's strain on the right ventricle, there's some signs that we can look for with ultrasound that are actually quite helpful. We can look for dilated RV, we can look for D sign, we can use McConnell sign, and we can utilize our TAPSE measurements. Let's go over this briefly. Here we see an apical four-chamber view. We can see the right ventricle is significantly dilated. Normally, that should be 2/3 the size of the left ventricle. Here it's dilated. But in addition, we can actually see the RV apex, which is really cranking over there. It's very hypercontractile. And that's an example of McConnell sign, which is highly suggestive of a PE. In the parasternal long axis view, the RV should have approximately the same diameter as the LV, left ventricular outflow tract, as well as the left atrium. It should have a 1:1:1 ratio. If you see significant enlargement of the right ventricle, that's suggestive of increased right heart pressures. And in the left ventricle, in the parasternal short axis view, the left ventricle should really be taking up the majority of the view, with the right ventricle being draped over the LV and having an ovoid appearance. As opposed to this view in which the RV is significantly larger than the LV. And due to the increased pressures in the RV, you can actually see some flattening of that interventricular septum known as the D sign. If you have a high suspicion that your patient has a PE, you can also look at the vasculature of the lower extremity. In this case, we're looking at the femoral vasculature. We can see here the common femoral artery and the common femoral vein. And even with compression, the common femoral vein is not collapsing, indicating that there's a DVT. And in a patient who's hypoxic and short of breath, this is highly suggestive of a PE. Now, TAPSE is probably underutilized in the ED. TAPSE, which stands for tricuspid annular plane systolic excursion, provides a very nice global assessment of RV function. And it's been shown in multiple studies to offer prognostic information, including about the need for ICU level of care, as well as mortality outcomes. The view is obtained from an apical four-chamber view, and you're going to place the M-mode spike over the lateral tricuspid annulus. There is some controversy in the field, but usually we can use 16 millimeters as a cutoff. Anything below 16 millimeters is considered abnormal. And you're going to want to take the average over several cycles. So here we have an apical four-chamber view. You can see the M-mode spike has been placed over the lateral annulus of the tricuspid valve. And here we're measuring from peak to trough with a measurement of 28 millimeters, which is above that 16 millimeter cutoff. So this would be a normal value. Let's shift gears and speak for a few minutes about the use of ultrasound for a disease which has had an immeasurable impact on all of us for the last year, using ultrasound for COVID. When looking why would we use ultrasound? A year ago, if someone came in with respiratory distress, we knew that it was COVID. But then again, if someone came in with an ankle sprain, we knew that they also had COVID, most likely. And so now, with increasing number of people who are vaccinated, we have again our wide differential for people who are coming in with respiratory compromise. And the use of ultrasound early on in patient care allows for appropriate triage. It allows us to make sure that we do what we can to separate patients who have COVID from those who don't. And in addition, ultrasound allows us to assess how much of the lung has been affected by the virus. So we know that COVID-19 has a predisposition for infecting the lower respiratory tract. And from an imaging perspective, we're going to look for bilateral consolidations, an Apache distribution, and the consolidations tend to be out towards the periphery, which from a lung ultrasound perspective is actually helpful because that makes it more amenable to sonographic diagnosis, although the findings can be nonspecific. So what are we going to look for? We're going to see focal B lines with pleural thickening. We're going to see an irregular pleural line, as well as disruption of the pleural line. As the disease worsens, we're going to see diffuse B lines and subpleural consolidations. When the patient starts to improve, we'll see A lines. And it's unusual for patients with acute COVID to have pleural effusions. So if you see someone with a respiratory compromise who's got significant bilateral effusions, you should be thinking about a different etiologic agent. Here's a nice example of B lines and then some focal sparing, and then B lines, and then some focal sparing. This nicely demonstrates the patchy involvement of the lung in the setting of this illness. Here we have rib and shadow and rib and shadow, and just deep to the pleura, we've got these subpleural consolidations, which can occur in the setting of COVID. Now, normally the pleura, as you know, will be a thin, white, hyperechoic line. Here we have some irregularity of that pleura, which can be seen in COVID. And here's a more significant example of that, where we see a fair amount of disruption of that pleura, as well as some B lines. Here's another example of some discontinuity of that pleura, as well as a subpleural consolidation, which occurs with COVID. And this was a patient that I saw recently during a shift on the critical side of the ED. This was a 65-year-old male who complained of acute onset shortness of breath. He was somewhat tachycardic, but impressively hypoxic. And due to the times that we live in, he was triaged to the COVID section of the ED. And surprisingly, about 25 minutes later, his point of care COVID test came back negative. So based on that, he was moved out of that section and into the main part of the ED. And the ultrasound team happened to be coming by. And so they scanned the patient. And what they saw was the patient had diffuse B lines on the left side of his chest. And as on the right side, he also had diffuse B lines. Remember, this person had no history of cardiac disease. But also, if you look closely here, you can see that there's some irregularity and some thickening of the pleura. So based on this constellation of findings, there was concern that the patient may have COVID. You can ignore these other measurements, but here there was a measurement of TAPSE, and you can see that at 32 millimeters, he was well above the 16 millimeter cutoff. So based on these findings, he was moved back into the COVID section of the ED. And sure enough, about 2 hours later, his PCR came back positive for COVID. He was treated with steroids and admitted to the hospital, again, demonstrating the utility of early use of ultrasound. So looking ahead, where does this technology taking us? So we know that there's miniaturization of the ultrasound probes, as well as consistent improvement in image quality. We now have probes that can plug into our phone. There's some that can even connect to our phones wirelessly. And this is occurring simultaneously with big advancement in the field of AI as it relates to ultrasound, particularly through the use of deep learning, which uses large amounts of data to essentially teach machines how to interpret images through the use of neural networks. This was demonstrated nicely by Rob Arntfeld, who recently published a study in which they took over 600 videos, lung ultrasound videos. All of the clips had B lines, but the B lines were of differing etiologies. Some of the B lines were due to cardiogenic pulmonary edema. Some of the patients had ARDS due to COVID, and some of the patients had ARDS due to non-COVID etiology. And interestingly, after teaching the machine how to what the correct diagnosis was, and they then showed additional clips, and the computer actually performed better than ultrasound trained clinicians. So the authors postulate that there may be some subvisible characteristics, whether in the B lines themselves or in the pleura, which allowed the computer to perform better than the humans in interpreting the etiology of the B lines. So AI is here. FDA last year approved the first AI for ultrasound. Several machines, including those marketed towards the ED, already have AI software built in as part of their standard operating system. And the primary focus to now has been on the use of lung ultrasound and echo for AI, and with improvements both in image optimization as well as interpretation. So this is just going to make for a very powerful tool. I mean, we use ultrasound in the New York City area routinely when we have access to a tremendous amount of additional resources from an imaging perspective. Imagine if you were working in a rural part of the country where they had less access to CT, or in particular MRI, or outside of this country in low resource settings. This is a very powerful tool. So to bring it home, you really want to become an expert and facile with thoracic sonography by performing the scan early in any patient who comes in with respiratory compromise. And if there's any change in their clinical status, repeat the scan, see if anything's changed. From a COVID perspective, scanning these patients early on allows you to hopefully isolate them from the non-COVID patients in your ED, as well as allowing assessment of how much of the lung has been infected and affected by the viral illness. From a trainee perspective, you want to make sure you can differentiate rapidly and accurately between A lines and B lines, and then move on to pleura, looking for any irregularities, effusions, and consolidations. This is going to make you a better diagnostician and improve your patient outcomes by allowing them to be diagnosed faster and appropriate treatment initiated more rapidly. Thank you for your time.
Wow, Dr. Dickman, thank you so much. I really appreciate you taking the time to drop those knowledge bombs on us. And the one thing, if there's one thing that I've learned from you in particular, it's scan early and scan often, and don't forget to document it.
That's right. Thanks, Sally.
We have just a couple of quick announcements before we get on to our next speaker. I'd like to share with you something, super fun activity that's coming up for All New York City. Would you look at that? We're having a basketball tournament. This is grassroots resident organized. It's going to occur in June, on June 2nd in Brooklyn Bridge Park at 2 p.m. Below you see the contact information at gmail.com in order to sign up your team, sign up your program. And it looks like we're going to be kicking it old school in New York City with a good old-fashioned basketball tournament. Keep in mind that only fully vaccinated players are available, and I'm sure that there's some amazing hidden talent or not so hidden talent in our All New York City group. And you know, who knows, someone's going to get all Billy Madison on one of the other programs. As well, I invite everybody to hit up our newly designed website, allnyc.com, allnycem.com. It's really a great way to keep up with the events that we're doing, the activities that we're doing, and to stay abreast with what's going on with all the other programs in New York City. Take it away, Dr. Beck Esme.
All right. I think the theme of this morning's doctors is that they are all big ultrasound lovers. We had Dr. Wilcox pushing the ultrasound and how great the ultrasound was. And then of course, Dr. Dickman, and Dr. Haney Malamet is our next speaker, who is also a well-known ultrasound lover. We are just making sure that we have him on the correct link here. Brian, I think, is sending it to Haney right now. He maybe got on as a viewer instead of as a panelist. So while we get him on, I will tell you a little bit about him. He is the creator of the Critical Care Now website, which is a blog with all sorts of multimedia content on critical care and education that if you haven't checked out yet, you should. He's one of the few innovators right now using TikTok to bring medical education to the world, which is really fun. And he's a well-known national and international speaker. He practices both emergency medicine and critical care at Cooper University, but he really wants this audience to know that he is from Bayside, Queens. He trained in Brooklyn, and that New York City pizza is the very best pizza on the planet, and just try to prove him wrong. He's going to be talking to us about caring for the sick right ventricle. Let's just make sure we have him.
Just a quick note about our website while Dr. Malamet is getting locked and loaded. You're able to sign up for, using your email, you're able to sign up for notifications so you know well in advance when we're having events. And also, especially if you want to be notified anytime we're having a basketball throwdown, so you can get your program's team up and running. One of the famous alum from SUNY Downstate, Kings County, EM-IM, Dr. Haney Malamet.
Hello, how's everyone doing?
We're good, Haney, thank you.
Life's good, thanks for coming here. We're so happy to have you. I also agree that New York City pizza is beyond the best.
Absolutely, for sure. So are we running live? Want to do the talk? Ready to go?
Ready to go, no pressure. There's only approximately 770 viewers right now, but more because we know that we have a couple of residencies sitting live in a big open room together, so.
Wow, well, fantastic. Really, really good stuff. All right, well, let me get set up here. Just give me one moment to switch over screens. I have a certain way that I like to do presentations because we're all pretty zoomed out at this point. So let me get that all connected and let's see how that goes. All right, y'all can see me okay?
We are seeing you, but we are not seeing slides.
Oh, not yet.
There are slides.
Promise they're coming
Oh,
soon.
okay, good.
All right, and I'll check in. So again, my name is Haney Malamet. I'm an intensivist. I'm an emergency medicine doc, and I have a particular affinity for New York City. So anytime someone says come to New York City virtually or in person, I'm always down. And so I also have a very high affinity for ultrasound and resuscitation. And the thing I'd like to talk to you about today is the RV. Now, I already know that none of you care about the RV. Believe me, I know that's true because I've given this talk before and I've seen the looks on the faces in the audience. I've scanned with residents, I've talked about the RV and fellows, and this is pretty much the look that I get every single time when I talk about the right ventricle. So hopefully you're seeing these slides because what I want to do is I want to take you through and talk about how to manage the sick right ventricle. The right ventricle is an underappreciated ventricle. Everyone talks about the LV. We got to resuscitate the LV, fill the LV up. No one pays any attention to the RV. And hopefully by the end of this talk, you'll have a much deeper appreciation for the right ventricle. And we're only going to talk about two things during this talk. We're going to talk about how to visualize the RV and how to assess it. And then we're going to talk about how you manage the sick right ventricle. So let's get right into it. Let's talk about checking out the right ventricle. Now, for those of you who do ultrasound, this will be a very brief review on how to do it, but the RV can be seen in all four of the views that you scan in. But the one that I want to focus on is the mitral level view of the parasternal short axis view. Here's the normal scan. As you see here, you see that the LV is concentric and the septum, the interventricular septum, is always concave with respect to the LV. This is normal. And as you scan patients and you start to see flattening, the D-shaped septum, as they call it, of the RV, you'll notice that there's some problems. If you want to take it up a notch and really be good with ultrasound, when there's flattening during systole, you'll note that there's a pressure overload happening on the right side of the heart. And when there's flattening happening on the, when there's a volume overload, there'll be flattening during diastole of that interventricular septum. That's just like some bonus pearls. But just know when you see flattening, there's some abnormality on the right side and you should pay attention to it. As we move on, we'll talk about the apical four-chamber view. This is the best view to compare the RV to the LV side by side. And what you're going to do here, and this is a normal view again, just to get your feet wet here, is the RV should always fit inside the left ventricle. Normally we say that the RV should be 2/3 the size of the LV. But again, I like that, just being able to visualize it going into that LV as normal. And then of course we have gradations of abnormalities. If it's between 2/3 but not quite 1-to-1, then we think that that's mild dilation, as you see right here. Once the RV is the same size as the LV, we think about moderate dilation of the RV. Again, these are all abnormalities that should make you think that there's a problem. And when your RV is bigger than your LV, kind of like where you're like, is my probe marker turned one way or the other? That's when you think that the RV has severe dilation. Now, it's not enough just to know that the RV is big. You'd like to know what the systolic function is. Now, I'm going to give you a term. If you really want to be smart and academic and walk around and alienate everybody with ultrasound, I want you to start using the word TAPSE. And TAPSE is essentially looking at the RV function. Now, the LV contorts in like 6 different dimensions. The RV is very simple. It goes in one dimension like an accordion. It goes from the base to the apex and contracting. And so that's why I use this term TAPSE, which is tricuspid annular plane of excursion. Don't even remember what it stands for. Just say TAPSE and you'll be a badass. But what you want to do is you want to focus on the free wall, the free annulus of that right ventricle, of that tricuspid valve, and watch it move up and down. So as you see here where the star is, you're looking right at that lateral annulus of the tricuspid, watching it bounce up and down. And the more it bounces, the more normal it is. If you want to remember numbers, greater than 17 millimeters movement from diastole to systole is normal. Less than that indicates that there is systolic dysfunction. But just remember, tricuspid annular plane of systolic excursion. Here's just a quick example of an RV that's not performing well systolically. And you can go ahead, you can measure this with M mode, things I won't bore you with, but you can just eyeball this and say, this is a low systolic function with a big RV. There's a problem on the right side of this heart. Now, for those of you who have scanned many hearts, you might see a big RV, but it's performing well. And you're trying to figure out whether or not that RV is acutely dilated or chronically dilated. So people with COPD, pulmonary hypertension, they may have chronically dilated RVs as the RV has built up muscle over time trying to accommodate for that pulmonary hypertension. Well, the way you're going to do this is you're going to go to your subcostal view. You're going to get that good subcostal view, and what you're looking for is the free wall of that right ventricle. For those ultrasound nerds out there, you just want the beam to be perpendicular to the surface that you're measuring. And then you're going to freeze during diastole, and you're going to measure. The measurement you're looking for is 5 millimeters or less. That is a normal free wall of the right ventricle. The RV is not as strong. It's kind of puny compared to the LV. So 5 millimeters is all you're looking for. And if you have somebody, just as you see here in the star, if you have somebody who has RV dysfunction, then you're going to be seeing something like this, a big, thick-walled free wall. Now, I misspoke. It's not actually dysfunction. You have a large RV with increased size of the free wall during diastole. Anything over 5, so 6, 7, 8 or more, tells you, yeah, this RV is big, but it didn't just happen today. It's not like an acute PE. This RV is getting dilated over time and getting stronger over time because it's dealing with increasing pressures. So just keep that in mind. When you see a big RV, the next branch point on your decision tree, is it acute or chronic? Do that subcostal view, look at the free wall, and then you'll make your determination from there. So let's move on and talk about the sick RV. Now, this is really important when you're doing resuscitation. We're talking about things where people come in with PEs, or they have acute on chronic pulmonary hypertension. The headlines these days are people with COVID. Severe hypoxemia alone could cause pulmonary artery vasoconstriction that can lead to a dilated RV. Any one of those pathologies is going to lead you into the RV death spiral. And this is really important to understand conceptually, because when we go to resuscitate the RV, we're going to be keeping these things in mind. But let me walk you through the death spiral. So whatever the insult is, you're going to have an increase in RV afterload. So if you have severe hypoxemia, we'll stay with that COVID example, you're going to have pulmonary artery vasoconstriction. And what that means is that puny RV is not going to be able to squeeze against that increased resistance. So what happens is that RV dilates. When that RV dilates, what happens? When that RV dilates, what happens is it doesn't allow perfusion. Get this back up online. It doesn't allow perfusion of the coronary arteries, which are perfusing through the myocardium. So as it dilates, it doesn't like this slide at all. So I'll just talk it through. How's that? So as it dilates, as that RV dilates, the myocardial fibers are squeezing the coronary arteries in there, and now you can't get perfusion to the myocardium. And what happens? The myocardium becomes ischemic, and it doesn't pump effectively to the LV. And when it doesn't pump effectively to the LV, what happens? Well, you get a decrease in cardiac output. And if you don't get an increase in cardiac output, you get a drop in your mean arterial pressure. A drop in your mean arterial pressure means your coronaries aren't filling, and that leads to further dysfunction of the RV, and that cycle continues on, and that's the death spiral. So you want to break that death spiral. So how do you do it? There's two ways you resuscitate the right ventricle. I want you to think about this framework. This is the 30,000-foot view. We're going to think about resuscitating the right side of the heart, and we're going to talk about minimizing hypotension. So let's talk about the right side of the heart first. Your goal is, when you find a big dilated RV and you think that's the problem, is to start to augment the preload. What I mean by that is you can consider giving those patients fluids, but this is not the situation where you're going to give bolus after bolus after bolus. The RV Starling curve is very different than the LV. The RV can't tolerate lots of fluids at baseline, let alone when it's sick. So you can try giving small aliquots of fluid. I like to give 250 at a time and see if that makes things better. And I certainly wouldn't exceed 1 liter for these patients. Every patient's different, but I'm just giving you a global approach to it. So I'll try increasing the preload a little bit. My next step, and the step I'm going to be relying the most on, is to increase the squeeze of that RV. I'm going to increase contractility. That RV is down. I want to push blood forward, which is going to avoid that death spiral. So we increase contractility. Sometimes that's not enough. You need to also increase the afterload in the pulmonary artery vasculature. So we want to increase the squeeze and also at the same time vasodilate. And you could use things like inhaled nitric oxide or ibuprostanol, inhaled milrinone. Some people even use inhaled nitroglycerin. So there's lots of different ways you can vasodilate. The next thing that you can do that will minimize that afterload is to make sure that you are minimizing hypoxemia. Hypoxemia causes a reflex vasoconstriction. So give your patients ample oxygen, right? Give them whatever it is, high flow or non-invasive. Make sure that you oxygenate these patients well. The other thing you want to minimize is hypercarbia. Normally with COPD patients will tolerate some hypercarbia, but remember when they get hypercarbic, they become acidotic, and that causes pulmonary artery vasoconstriction. Okay, so before we leave the RV, quick review. We want to increase the preload a little bit, but not too much. We want to increase the squeeze of the heart while we're increasing the dilation of the pulmonary artery vasculature. That's going to make blood move through that right side to the left side much easier. The next thing you want us to consider is minimizing hypotension. Now you will see these people and you'll have this inkling like you want to intubate them. Try to fight that urge because as we all know, intubation leads to hypotension. Some studies say in up to a third of patients who are critically ill. I'm not saying don't intubate patients with pulmonary hypertension, but be sure you move through all these steps first before you intubate them. Because when you intubate patients, what happens is they become hypotensive, and then we go back to that side of the problem, and we're increasing the afterload on that RV. So we want to wait as long as we can to minimize intubation for these patients. Now, if you do have to intubate these patients, there's a strategy to this. And many of you are familiar with minimizing the amount of sedation you use for patients when you go to RSI them, because any sedation, even if it's ketamine, is going to cause hypotension. So giving smaller aliquots of your sedative hypnotic to get them ready for intubation would be a wise move. The best move would be to do an awake intubation where you topicalize them. But in the case you can't do that, minimize your sedation until they dissociate. And I say dissociate because I like to use ketamine, and then give full dose paralytics for that patient. Before you make that move to intubation though, I would get this person fully resuscitated. What I like to do is I like to use vasopressors, and my preference is actually to use vasopressin first. The reason why I say vasopressin first is because vasopressin is the least pulmonary artery vasoconstricting of all the vasopressors. Norepinephrine is pretty good, but still causes pulmonary artery vasoconstriction. Vasopressin causes peripheral vasoconstriction, where you want it to be, but not as much in the pulmonary artery. Things like neosynephrine and dopamine, if anyone's using dopamine, cause pulmonary artery resistance, and that's the antithesis of what we're trying to do. So if you're gonna get ready to intubate them, start them on vasopressors, vasopressin or norepi first. The other thing I like to do before intubation is I like to place an A-line. Now, people say, we got to RSI this person, we got to RSI them. But if you don't know what that person's blood pressure is, you can't respond to it. If it's dropping, you have to wait for that cuff to cycle. So if you have the ability to get an A-line in, get that A-line in, and then know what your blood pressure is as you're going to intubate them. And then the last thing I'll say is that for your ventilator, be sure that you minimize the settings on your ventilator, because the vent can also cause strain on the RV. PEEP, too high of tidal volumes, hypoxemia, hypercarbia can again affect that right side of the heart. So when you set your PEEP, set it to the lowest amount possible that will get you oxygenation, and try to minimize your FiO2 just at that point where you're getting good oxygenation. But if you need to give them more, because remember, hypoxemia causes vasoconstriction. If you remember all these things, you will have much more success resuscitating the person with the sick RV. But don't forget to identify that person first. And then once you've identified them, avoid them from going to that RV death spiral. I really want to thank you all for your attention. Please don't hesitate to reach out to me. I'm on social media at Critical Care Now, but thank you for the invitation. And it's always good to come back to New York, even if it's virtually.
Thank you so much, Haney. That was outstanding. We had actually a couple of questions from the audience that I was wondering if you could address. The first was a comment from Dr. Pik Mukherjee, who asks, Haney, did you just say nitroglycerin to increase afterload? Vasodilators? I'm confused.
If I said increase afterload, my apologies. Inhaled nitroglycerin, which I have no personal experience with, but Josh Farkas has talked about, and Sarah Krieger, I believe as well, giving it inhaled can cause pulmonary artery vasodilation. Pulmonary artery vasodilation. You get systemic when you go intravenously. Inhaled can possibly cause pulmonary artery vasodilation, which again is the name of the game.
Amazing. Thank you for that. Also, from the vast internet, we have T-Serb who asks if you titrate vasopressin or if you're using it as at a fixed rate.
Yeah, people ask this a lot, and the study that went at we used to use 0.04, now we're down to 0.03, and people think it's this fixed rate thing. There's no rules. You do what's right for the patient, and I will titrate vasopressin if I find that it's a vasopressor that people respond to. So this is kind of a departure from what I'm talking about generally, but everyone thinks it's norepinephrine first and vaso, and usually that's the case, but it doesn't always work that way. There are patients that are vasopressin depleted, and you don't know until you try. So if I get to my mid-range, like I call that like 15 or 16 of Levophed, I'll start vasopressin. And if the Levophed requirements or the norepinephrine, we got to be academic, comes down, then what I'll do is I'll stick with vasopressin. And when I get them off the levo, I'll titrate down the vaso if as they tolerate it. But just know that there's no rules. You can do whatever you want in critical care as long as it's right for the patient. The most important thing is to listen to the paper, not listen to what people have said before.
Amazing. All right, everyone, you've heard it from the expert horse's mouth. There are no rules. Seems like critical care would have been a better career for me and many of the other people I know on this cast today. Thank you so much, Haney, for joining us. You always really exceed our expectations, and I always learn something new. I look forward to your next TikTok dance. And again, Critical Care now on Instagram. Immediately follow. You won't be disappointed. Whew, how about that? That was a pretty busy and action-packed first segment. I'd like to invite everybody to take a bit of a break, stretch your legs, make a coffee. We're actually gonna give you enough time that should you decide to make bacon and eggs, again, you do you. We want everybody to be exceptionally happy and comfortable today. Please return at 9:50, 10 minutes to 10, as we start our next segment. That is a 20-minute break. Thank you so much. Talk to you soon, everyone. See you back here.
back here is hands-on. What's the beef? The coolie high code chiefs, high post techniques. I drape off poetic landscapes and shapes. Illustrate the paper space off the pens that paint. Then design what habit National Geographic or magic with tailor-made status and plus flavor that's automatic.
We're not falling, we take it back to the days of yes, y'allin'. We're holding on to what's golden.
On the stage I rage and I'm rolling.
We're not falling, a shot calling. We take it back to the days of yes, y'allin'. We're holding on to what's golden.
On the stage I rage and I'm rolling.
Melancholy, mundane, sauteed, a hot flame, big rings, fat chains, they all quest for the same. No name, huge fame, strictly new to the thing. We stay true to the game and never bring it to shame. We tight like dreadlocks, a red fox and ripple. We pass participles and smash the artist in you. The saga continues. This I won't get into, cause there ain't enough bars to hold the drama that we've been through.
Yo, we still the same with a little fame, a little change in the household name, but ain't too much change. We in the game, yo, but not to be vain. I refrain from salt grains to season up my name. We entertain for a mutual gain from close range, steady aim. A drum at your head to hit the brain. I'm labor ready, roll scholar for the dollar. Work for mines, pay me by the hour.
We're not falling, we take it back to the days of yes, y'allin'. We're holding on to what's golden.
On the stage I rage and I'm rolling.
We're not falling, a shot calling. We take it back to the days of yes, y'allin'. We're holding on to what's golden.
On the stage I rage and I'm rolling.
Music, that music, new music, that music, new music, that music, new music, that music, new music, that
Yo, well, it's the verbal Herman Munster. Races as we punk you for your chart spaces. That taunt tastes me bringing these hot styles through. Some of you bum a few cheers from shock value. Word power can plow through acres of cornfields. Paragraphs cut like warm steel, perform ill.
We're not falling, we take it back to the days of yes, y'allin'. We're holding on to what's golden.
On the stage I rage and I'm rolling.
We're not falling, a shot calling. We take it back to the days of yes, y'allin'. We're holding on to what's golden.
On the stage I rage and I'm rolling.
I was standing downtown, staring at the puddles on the ground, trying to figure out a way about this town. And oh, yeah, I'm not the only one. So many people out there chase the sun. If you're looking for a free ride, you better run, child.
ice on your ways, front way, back way. You know that I don't play. Streets not safe, but I never run away, even when I'm away. OT, OT, there's never much love when we go OT. I pray to make it back in one piece. I pray, I pray. That's why I need a one dance. Got a Hennessy in my hand. One more time before I go. Higher powers taking a hold on me. I need a one dance. Got a Hennessy in my hand. One more time before I go. Higher powers taking a hold on me.
Baby, I like it so.
Strength and guidance, all that I'm wishing for my friends. Nobody makes it from my ends. I had to bust up the silence. You know you gotta stick by me. Soon as you see the text, reply me. I don't wanna spend time fighting. We got no time, and that's why I need a one dance. Got a Hennessy in my hand. One more time before I go. Higher powers taking a hold on me. I need a one dance. Got a Hennessy in my hand. One more time before I go. Higher powers taking a hold on me.
Down, I'll take it slow, make you lose control. Cause if you're down, cause if you're down, cause if you're down.
I need a one dance, got a Hennessy in my hand. One more time before I go. Higher powers taking a hold on me. I need a one dance. Got a Hennessy in my hand. One more time before I go. Higher powers taking a hold on me.
My name is Jonas. I'm carrying the wheel. Thanks for all you shown us. This is how we feel. Come sit next to me, pour yourself some tea. Just like grandma made when couldn't find sleep. Things were better then, once but never again. We've all left the den and typewriting. Choo-choo train left right on time. Ticket cost only your mind. Driver said, hey man, we go all the way. Of course we were willing to pay. My name is Wakefield. Got a box full of your toys. The fresh out of batteries. But you're still making noise, making the noise. Tell me what to do. Now the tank is dry. Now this wheel is flat. And you know what else? Guess what I received in the mail today? Words of deep concern from my little brother. The building's not going as he planned. The foreman has injured his hand.
I was just a little girl, skinny legs and pressing curl. My mother always thought I'd be a star. But way before the record deal, streets that nurtured Lauryn Hill made sure that I never go too far. Every ghetto, every city, and suburban place I've been make me recall my days in the New Jerusalem. Story starts in Hooterville. Grew up next to Ivy Hill when kids were stealing quarter bills for fun. Killed a guy in Carter Park. Rode a mongoose till it's dark. Watching kids show off the stolen ones. Every ghetto, every city, and suburban place I've been make me recall my days in the New Jerusalem. You know it's hot, don't forget what you got. Looking back, looking back, looking back, looking back, looking back. You know it's hot, don't forget what you got. Looking back, looking back, looking back, looking back. Vagabond times 20 cents and a nickel. Springfield Lab had the best popsicles. Saturday morning cartoons and kung fu. Main Street Roots tonic with the dress. A beef patty and some cocoa bread. Move the patch from my leaves to the tongue of my shoe. Remember, Freeland Heiston used to have the bomb leather. Back when Doug Fresh and Slick Rick was together. Looking at the crew, we thought we'd all live forever. Yeah, you know it's hot. Don't forget what you got. Looking back, looking back, looking back, looking back. You know it's hot. Don't forget what you got. Looking back, looking back, looking back, looking back. Drill teams on Munn Street. Remember when Hawthorne and Chancellor had beef? Moving Records was on Central Ave. I was there at dancing school, South Horn Jab at bowling pool, unaware of what we did and had.
Oh man, is there ever some guilt in turning off Lauryn Hill? She is the best. I swear to you, I must have listened to the Miseducation of Lauryn Hill approximately 500 times the year it came out. Welcome back from your break. I'm sure some of you went outside to walk your dogs. Some of you had breakfast. Some of you stretched your legs. Some of you, the motivated few, jumped on the Peloton for a quick ride. But now we're all back here and we're happy to have you. So without further ado, we have a couple of really exciting segments for you today. Dr. Duncan Grossman is a chief resident at Maimonides Medical Center in Brooklyn, New York. Next year, he will be a medical education fellow at St. Joe's in New Jersey. And today he's bringing us a curbside consult. Take it away, Duncan.
Hi, my name is Ankit Goel. I'm a EM pharmacist at Maimonides Medical Center. I did my PGY2 in emergency medicine pharmacy here about 4 years ago, and I specialize in resuscitative care.
Ankit, can you tell me from a pharmacology perspective why push-dose pressors even make sense?
Sure. So when we look at any drugs that are continuous infusions, they typically have to build up to a level in the body known as steady state. Now, kinetically, steady state is defined as the amount of drug coming into the body is equal to the amount of drug being metabolized and eliminated from the body. Now, most drugs typically take about 5 half-lives to reach this steady state. And so for all of our pressors, they typically have half-life somewhere in the range of 1.5 minutes to 2 minutes. So it may take up to about 10 minutes to see the full effect of a pressor. And if you have a crashing patient, 10 minutes can make or break outcomes. And so the idea of a push dose pressor is to give a patient steady state like concentrations. We can mimic the concentration of drug in the body to to look as if it's like steady state until our continuous infusion can kick in.
Okay, you want to show me how to make some of them?
Sure. Let's get it going. No, please cut that out. No. Don't, Duncan, please. No. This particular epinephrine is the 1 in 10 ml. So this is the code dose epi, or the 0.1 milligram per ml. Start off by opening the box. And you'll get these 2 ampules right here. It's called a Bristajet. You attach the Bristajet on, and we're trying to make 0.01 milligrams per ml. So we have to do a 10 times dilution on it. So what you do is you take 1 ml of code dose epi, inject it into a 10 cc syringe, and 9 cc's of sodium chloride. All right, and there's your push dose epi. So each ml is 10 micrograms. So the typical dosing is anywhere from half an ml to 2 mLs per dose. We're essentially giving a bolus of this drug to give the patient a steady state like concentration until the epinephrine drip kicks in. Typically, these push doses wash away within their 3 to 4 half-lives. And so you might have to redose again in about 6 to 8 minutes. So it's important to not give push doses and walk away from the bedside. There are 2 different ways that we can make this. So depending on your institution, you can purchase a pre-made norepinephrine bag, which could vary from 8 milligrams and 250 or 4 milligrams and 250. So just double check your institution to see what concentration you carry. This particular bag is 32 micrograms per ml, which is pretty concentrated. If you have a crashing patient and they need some pressor, we can draw out 1 ml knowing that there's 32 micrograms in here. And we can give small aliquots of half a cc, which will be 16 micrograms, which is within the range of where we want to dose our patient, anywhere from 5 to 20 micrograms at a time. You might not have these pre-made bags, and so you might carry these much more concentrated vials, which is 4 milligrams and 4 mLs, or 1 milligram per ml. So you crack the ampule, you withdraw 1 ml of norepinephrine using a filter needle, because we don't want to inject our patients with glass. Change out your needle and inject 1 ml, which is 1 milligram of norepinephrine, into 100 cc's. Now we have a concentration of 10 micrograms per ml within this bag. So the concentration of this is 10 micrograms per ml. And the typical dosing that we would give to a patient is anywhere from half an ml to 2 mLs, or 5 micrograms to 20 micrograms at a time. So this is a commercially available product that we purchased. So we thankfully don't have to prepare push dose phenylephrines. There is a concentrated phenylephrine used to make phenylephrine infusions. Now, if you notice the concentration, it's 100 milligrams and 10 mLs. So we're talking about 100 times the concentration in here than what is in the stick. So I do heed some caution with using this, because 100 times dosing errors have occurred before. There are many reports of it with this particular product. In order to prepare a push dose phenylephrine, you take 1 milliliter of this concentrated product into a 100 cc bag. So I'm putting 10 milligrams inside of 100 cc's. So the concentration then becomes 100 micrograms per ml, which is the same concentration as this phenylephrine stick. Now you can draw out of this bag and have the same concentration of phenylephrine in here as you do in this push dose phenylephrine. The push dose phenylephrine is 100 micrograms per ml, which is a little different from our other push doses, which are typically 10 micrograms per ml. Typical dose is anywhere from a half an ml to 2 mLs, which is 50 to 200 micrograms.
if you were a crashing patient and I was gonna drop some push dose pressors for you, what would you want me to give you?
So I would prefer push dose phenylephrine just because of the sheer convenience of it. It's ready made in a lot of places. It's quick to get. It doesn't involve complex mental math. I would ideally want push dose levofed in a perfect world. I think it's a superior pressor to phenylephrine in certain disease states, but in our imperfect world, push dose phenylephrine is probably your pressor of choice.
And all right, thank you, Trisha.
Thank you, Duncan.
Bye. You guys have a good shift, okay?
All right. See you later, Duncan.
Bye.
How about that? Where would we be without our spectacular ED pharmacists? I swear they must save our patients' lives on a day-to-day basis. Okay, thanks so much, Duncan, for that outstanding review with Ankit. And next up, we have Dr. Ruben Strayer. He is the author of EM Updates, and he's an emergency doctor, of course, based in New York City. His clinical areas of interest include airway management, analgesia, opioid misuse, procedural sedation, agitation, decision-making, and error. Turns out he's a very interested person. His extra clinical areas of interest include sweeping generalizations and jalapeno peppers. He lures himself out of bed with chocolate every morning before heading to Maimonides Medical Center in Brooklyn, New York, where he is happily employed. I will also add that Dr. Ruben Strayer bakes a spectacular brownie, and I have benefited from these brownies in the midst of a shift, but beware the gut bomb. Thanks so much, Ruben, and take it away.
Thanks, Sally. Hi, everyone. Pleasure to speak to all of you virtually at this fabulous conference. I'm Ruben Strayer. I'm an airway enthusiast, but also a chocolate and peanut butter enthusiast. So I just wanted to make everyone aware of this new product from Reese's, a peanut butter cup without the chocolate. It's a pretty exciting development, and now you have many choices when it comes to chocolate and peanut butter cups, but we're going to focus on airway choices and discuss how to think about our current menu of intubation modalities. And it's a menu with a lot of options, but it wasn't always so. In the earliest days of emergency medicine, emergency docs did not have access to paralytics or the powerful induction agents we love so much. So the only option was blind nasotracheal intubation, which is a procedure most of you have never heard of. And just as well, it is a brutal, often unsuccessful technique where you jam an endotracheal tube into the nose of an awake patient, hope it aims at the vocal cords, and then by listening to breath sounds through the tube, which is what's pictured here, you try to time advancing the tube with the opening of the cords. All this done completely blind, horrendous. Gaining access to succinylcholine was one of our crucial milestones, allowing patients to be safely and humanely intubated using a traditional laryngoscope. Developed in its present form in 1943, if you were really fancy, you would avail yourself of different blades, like the Miller blade, which remains popular in pediatrics. This is a McCoy blade, which has a hinged tip you control with that lever. There were all sorts of variations on this theme, but for decades, just about every emergency department intubation was done using a traditional laryngoscope. We didn't call it a traditional laryngoscope, of course, because it was the only laryngoscope, and most of the time this went well, but often enough, not, because lots of patients have difficult airway anatomy. So a variety of alternatives were developed, including retrograde intubation, where you introduce a wire through the cricothyroid membrane and retrieve that wire through the mouth, then use it to guide the tube through the cords. And then there was the trach-lite, which is basically a lightsaber that you use as a stylet. You blindly insert it and just keep horsing around until the light gets really bright, which suggests you're in the trachea, and then you can advance the tube. I was halfway through my residency in 2005 when the air track was introduced. Instead of trying to push the tongue out of the way, this rather genius device allows you to see around the curve of the tongue using a series of mirrors and prisms, which seemed like magic, even if it was a little awkward to use. Meanwhile, upstairs, anesthesiologists used expensive, fragile fiber optic bronchoscopes to manage their difficult airways with a topicalized awake technique, which is very safe because the patient is completely awake. But the problem with topicalized awake for emergency medicine is that it requires time and patient cooperation and a skill set that is not well taught, and equipment like atomizers and concentrated lidocaine that isn't always available. Although the piece of equipment that has been hardest to make available downstairs, the flexible endoscope, is rapidly becoming more available. And I'll come back to that in a minute. The GlideScope was invented in 2001, but became popular over the course of that decade. And this device changed everything. But it also confused everything because it simultaneously introduced two distinct technologies: videolaryngoscopy, which is putting a camera at the end of the blade, and hyperangulated geometry, which is a very steeply curved blade. And it took us a decade to understand this, and many still don't understand. But I hope by the end of this talk, all of you will understand. These two technologies are radically different in their importance. Videolaryngoscopy is an indisputably transformative advance that has changed everything. But hyperangulated geometry is a comparatively marginal advance and is in fact a trade-off compared to the alternative, the standard geometry blade. But because these two technologies were introduced simultaneously in the same revolutionary device, it has caused a lot of confusion. Let's try to untangle it. Direct laryngoscopy is using a laryngoscope to clear out a path in between your eye and the patient's glottis so that you can see the glottis with your own eyes. Videolaryngoscopy is using a blade with a camera at the end of it to project an image of the glottis onto a video screen so that you see the glottis not with your eyes, but on the screen. Traditional laryngoscopy is what we were all doing before video using the 1943 laryngoscope. You often hear this referred to as direct laryngoscopy, but that's imprecise and confusing because, as I will emphasize, you can do direct laryngoscopy with a video device that has a standard geometry blade. A standard geometry blade, like a Macintosh or Miller, is designed to move the tongue out of the way so you can perform direct laryngoscopy and see the glottis with your own eyes. In addition to performing DL with a standard geometry blade, you can also put a camera at the end of a standard geometry blade and project the glottis onto a video screen. Hyperangulated blades have a much sharper curve and are designed to get the camera at the end of the blade around the tongue to project the glottis onto a video screen. You cannot do direct with a hyperangulated blade because they don't move the tongue out of the way. They get around the tongue. So with SGVL, you can do direct or video. With HAVL, you can only do video. And of course, with traditional laryngoscopy, you can only do direct. The most popular video laryngoscope manufacturers produce standard and hyperangulated blades. Here you can see the GlideScope offerings and likewise with the CMAC system. So avoid the terms VL and DL when you're talking about an airway modality because those terms don't tell enough of the story. And certainly don't use a brand name like GlideScope or CMAC when what you mean is a blade type because that's incorrect. And one last time, if you're using a traditional 1943 laryngoscope, you're looking in the mouth. With a hyperangulated blade, you're looking at the screen. And with standard geometry video blade, you can look in the mouth or at the screen. Okay, so with all that background, we can move on to talk about some airway choices. Ever since the advent of video laryngoscopy, there has been a raging VL versus DL debate, which is a debate I think is finally going away because it only makes sense if you mean traditional laryngoscopy versus hyperangulated. To compare traditional and standard geometry video makes no sense because an SGVL blade can be used as a traditional blade or a video blade. SGVL obviously beats traditional. If you don't have standard geometry video, if you have to choose between hyperangulated video and traditional laryngoscopy, that's a valuable comparison. But this question is also becoming less relevant because more of us are using video systems that allow you to swap a standard geometry blade and a hyperangulated blade on the fly. Most modern video systems do both. So now that we are all using these hot swappable devices, DL versus VL has become a silly debate. The debate in 2021 is which video blade to reach for first. And the corollary to this development is when you have access to standard geometry video blades, which hopefully all of you do, there is no reason to ever pick up a traditional laryngoscope. The only reason to stock them is in case your video system breaks. Not everyone is going to like this statement, but the impulse and desire to use a traditional laryngoscope in 2021 is just bravado. There is a pervasive sentiment that using video is cheating, that real emergency docs intubate with traditional laryngoscopes. But this is misguided and dangerous, and in a training environment is probably reckless, as it is very difficult to assist a learner who is using a traditional laryngoscope because you have no idea what they're seeing. And half the time, the learner also has no idea what they're seeing. So now we can approach the trickier and more interesting question of standard geometry video versus hyperangulated video. And the first point to make is that if you are good at either technique, you are going to successfully intubate just about everyone. They are both fabulous techniques, but there are key differences. And the first is that it is significantly easier to achieve a good view of the chords with a hyperangulated blade. And that is a big deal, especially among infrequent intubators, because seeing the chords calms you down, and you do a better job when you're calm. Furthermore, HAVL requires much less force than SGVL because you don't have to move the tongue out of the way. And this is potentially important in a patient with a cervical spine injury, for example, or a tongue mass, which is at risk to bleed if disturbed. But that easily acquired fabulous view that you get with a hyperangulated blade comes at a price. And that price is tube delivery. It is considerably harder to get the tube through the chords with HAVL because your view on the other side of that curve points up, but the trachea points down. There are ways to overcome this, and these skills are crucial when doing HAVL, but they're poorly taught and they're counterintuitive. And the goals are essentially opposite of your goals when using a standard blade. Standard geometry laryngoscopy is faster than hyperangulated laryngoscopy. You can use a bougie with a hyperangulated blade, but it's more straightforward with a standard blade. And a bougie is a very powerful device. For the same reason, it's easier to use suction with SGVL, and this can make a big difference in contaminated airways. And standard geometry laryngoscopy uses the same skill set as DL, which has important implications for training. Both hyperangulated and standard video laryngoscopy are far superior and far more important in 2021 to master than direct laryngoscopy. Again, the only reason you need to know DL is in case you don't have access to video. And the way to get good at DL is to learn video first, specifically standard geometry video. You should not be attempting DL until you are very comfortable with VL, because VL is how you learn the anatomy, which you can barely see with DL. And VL is how you learn laryngoscopy technique, because you're attending barking, "What do you see now? What do you see now? What do you see now?" While you're trying to figure out what the hell you're looking at is not a recipe for success. The skills you hone learning SGVL work with your intuition and apply to direct laryngoscopy, much less so with hyperangulated. And once you get good at standard, you can pretty easily learn HAVL, but the reverse is not true. Therefore, the right way to learn laryngoscopy is to get comfortable with standard geometry video, then acquire the separate skill of hyperangulated video, and then start practicing direct with your standard geometry blade. And now the market for airway equipment and everything else is single-use disposable. And prices are coming down. Many departments now have a video laryngoscope with hot swappable single-use blades in a variety of shapes and sizes, which is quite a powerful tool. And now we have second-generation intubating supraglottic devices that are easier to place and designed to transmit an endotracheal tube. And most recently, we have seen the rise of the single-use flexible endoscope. This is a game changer for emergency medicine because it is impossible for many departments, especially departments with trainees who are barbarians, to maintain and keep sterile a traditional fiber optic bronchoscope. But these barriers disappear with a disposable flexible endoscope. And like the other innovations we've discussed, these are very powerful devices that greatly expand our capabilities. These new tools can work together in extremely powerful ways, and we haven't properly updated our airway strategy to take advantage of this. Here's an example of a strategy that does. It's posted at emupdates.com/choices with a detailed explanation, which we don't have time to discuss today, but I'm going to close by hitting a couple highlights. The first step is to decide whether to paralyze or keep the patient breathing. Most of the time, you're going to paralyze, but ask the question. Know the predictors of anatomic difficulty and know when a breathing technique is more likely to be the right choice. If you decide on RSI, which you will most of the time, do not rush, slow down, think, prepare. A checklist is a good idea. And the most flexible, powerful, foundational, scalable airway modality is standard geometry video in conjunction with a bougie. If you get good at this technique, you will almost never or never encounter an airway that you cannot intubate. If you do not achieve an intubatable view after performing these optimization maneuvers, you should place an LMA and establish ventilation. That's plan B for breathing, which will be successful nearly every time. On the rare occasion that it isn't, you're now in can't intubate, can't ventilate, and the next step is plan C, cricothyrotomy. If ventilation is reestablished with an intubating laryngeal mask and you have immediate access to a flexible endoscope, you can employ either of two tremendous techniques that seem advanced, but are actually quite easy and are very likely to lead to success. Flex endo-laryngeal mask intubation is a beautiful procedure that allows you to ventilate during intubation if you use a swivel valve. You place the LMA, then load an endotracheal tube partly into the LMA, then put your endoscope down that tube, which will deposit the tip of the endoscope right above the vocal cords, which usually are very easy to navigate through, after which you just advance the tube over the endoscope and you're done. Or once you've reestablished ventilation with your laryngeal mask, you can switch to hyperangulated video, which when combined with flexible endoscopy, a two-person technique, is an outrageously effective strategy to intubate anatomically difficult airways. In this technique, ideally, the assistant is ready with a flexible endoscope at bedside. You can see here, I'm helping the operator achieve a view by performing external laryngeal manipulation, but not helping well enough. There's still no view. So the VL operator holds their best view and take a step to the left as the endoscopist slides in to the right, loads the endotracheal tube onto the scope, and first using the VL screen, and then if necessary, the endoscope screen, navigates to and through the vocal cords. This is like using the endoscope as a super bougie, and in fact has been called the smart bougie technique, and it takes advantage of the primary strength of hyperangulated laryngoscopy, which is achieving a view of the glottis while minimizing its primary weakness, which is difficult tube delivery. Extremely powerful, effective technique, and not hard to do. So in summary, emergency airway techniques have evolved rapidly over the past decade, and our teaching and strategizing has not kept up. Take a critical look at the devices you stock in your department, what you should stock in your department, and how you can best take advantage of many choices to improve airway outcomes. Thanks everyone for your attention.
Wow, Ruben Strayer, that was exceptional. Thank you so much for updating our practice now that we have all these extra choices. How fortunate we are to have the technology. It's just up to us to A, use it, and B, teach our learners how to use it and how to use it in the right way. Would you say that's probably the thing that's lagging?
We're getting there. There's been so many advances over the past decade or so. It's hard to keep up, especially at training centers where you're trying to develop training paradigms. But I'm hoping that this will stimulate people to look critically at what they have, what they need, and what they should do with it.
Thank you so much. I really, really appreciate it. And I know that the 700 plus people out there feel the same way. All right, next up we have Dr. Eric Steinberg. I am proud to call Dr. Eric Steinberg a friend and a colleague and a co-board member for the All New York City EM group. He is a spectacular educator that really contributes to our approach and our goal for collaborative and innovative emergency medicine education. But he is also the program director at St. Joe's Health in Paterson, New Jersey. He did his emergency medicine training program at Mount Sinai Beth Israel, adjacent to Union Square. And he also got a Master's of Education at Johns Hopkins University. Eric stays active in the academic emergency medicine community by developing content for EMRA. He participates in content development for Foundations of Emergency Medicine and MD Calc during his free time, and who knows where he gets any of that. He likes to hike, drink bourbon, and build massive forts, not necessarily in that order, and he much prefers to do it with his two sons and all at the same time. And with that, I welcome Dr. Eric Steinberg.
Oh, wow. Thanks for that intro. I do not drink bourbon with my 4- and 2-year-old son. Just want to put that on the record. But good morning, everyone, and thank you for having me.
We're going to tackle PEA in just 15 minutes, so we're going to get right into it. So you are having a fantastic day, and your shift has been nothing short of awesome. You nailed that LP, you sniffed out that aortic dissection, and you're even all caught up with your charts. Heck, it's time to treat yourself to a 5-minute break and a $7 coffee. But just as you're about to make your great escape, the EMS notification phone rings. And what's it going to be today? What's coming your way this time? Amidst the poor reception and all the static, all you can hear is this. And before you can even get a single word in, the line abruptly disconnects. So PEA arrest, it's a total dumpster fire indeed. But why is that? Is it because we don't know what PEA actually means? Is it because every one of our colleagues seems to work up PEA in a completely different fashion? Or is it because no matter what we do, the outcome just seems to be the same, and that's our patient ends up dying in front of us? It's probably a little bit of all of the above. So in the next 14 minutes or so, this is what we're going to discuss: how to approach PEA our way for us, specialists in resuscitation. And when it comes down to it, when a patient arrives in PEA, we are already way behind the 8 ball. PEA is the presenting rhythm in about a third of arrests, yet it holds a 90% mortality. And that's significantly higher than patients who present with shockable rhythms. And so why is it for one of the highest stakes scenarios we'll ever come across in the ED, this is our approach, the kitchen sink. Let's just throw a whole bunch of crap at our patients and hope for the best? And with that being said, in the setting of PEA arrest, should a patient with this on her arm be treated the same exact way as this patient with this on his leg? Should a patient in PEA who's found down next to this be treated the same exact way as a PEA patient who's found down next to this? I think we could all agree the answer is no. So it's quite obvious that this kitchen sink approach, it wastes time, it wastes effort, it wastes resources, and more guidance is needed. And of course, that's the problem with PEA in the first place. There is no one-size-fits-all approach, right? There's such a wide spectrum of pathology that can result in the same exact rhythm. And well, ACLS is designed to provide us with this guidance, right? But what do? They tell us to consider the H's and T's, right? And we got to be real. How helpful is that? Let's just arbitrarily vomit out some random words at the bedside that start with H and T and hope we guess correctly. So we are better than this. We're better than ACLS, and we need to hold ourselves to a higher standard. So what is it that separates us from the rest when it comes to managing PEA? First, it's an understanding of the pathophysiology behind it. And we're going to distinguish true versus pseudo PEA, and then we're going to break down a couple of theories that can guide our resuscitation. And finally, it's utilizing our unique skill set to take a structured approach. So let's start with distinguishing between true and pseudo PEA. Now, in general, we think of PEA, true PEA, pretty simply. We look at the monitor and say, well, this rhythm should produce a palpable pulse, but I'm not feeling a pulse. And I'd say that's a decent start. But the more precise definition of true PEA is we look at the monitor and say, well, this rhythm should be resulting in evidence of end organ perfusion, but it's not. So in true PEA, it's not just an absence of a palpable pulse, but there's also an absence of end organ perfusion. They are not the same thing. It's critical that we keep this in mind. Now let's compare true PEA to pseudo PEA. We still have an organized rhythm. We're not feeling a palpable pulse, but there is evidence of organ perfusion. So in terms of our approach and our prognosis, we could see why this distinction may matter. And that brings us to our first key point. The absence of a palpable pulse does not equal the absence of perfusion. Well, how can that be? And simply put, we are horrible, terrible, no good at all at palpating pulses, especially in high stakes environments. And to quote Scott Weingart, we are reliably unreliable at finding pulses with our fingers. Our evidence suggests it, and our real life experience confirms it. It's terrifying, but it's true. And that brings us to our next key point, which is pseudo PEA is a profound shock state. It's not true cardiac arrest. Well, how can we tell if our patient's perfusing if manual pulse check is so abysmal? And I propose to you 4 tools. The first is POCUS, right? We've been talking about ultrasound all morning, and you are all amazing at this. Use color Doppler to check for femoral or even carotid arterial pulsation. If you can see this, there's evidence of perfusion. And who knows, you may even pick up that massive DVT while you're down there. So POCUS is likely the fastest way of obtaining critical information on your patient's perfusion status, and it's much more reliable than your fingers. Your next and most accurate option is placing an arterial line. And the magic number for adequate end organ perfusion is a diastolic blood pressure of over 30 to 40. So if you have the capability of doing A lines in your ED, PEA arrest would be the perfect time to consider doing so. Third, we can utilize end tidal CO2. And lucky for us, the magic number is the same, 30 to 40. Persistent elevations of 30 to 40 suggest adequate perfusion. And the obvious advantage of this is that it's easy and it's not invasive. And finally, let's say you don't have a team of overachieving residents to place the A line, or your ultrasound machine was taken away by your director to punish you, or you don't have that fancy schmancy capnography at your place. What is the quickest and dirtiest way to look for perfusion? Just look at the O2 sat. If there is a persistent waveform, there must be some perfusion going on. If there's a variable waveform or no waveform, maybe not. So quick recap, your POCUS pulse check, an A line, your end tidal, and O2 are great ways to assess for perfusion, much better than your fingers and trying to check a pulse. And again, why is this important? Because the presence or absence of perfusion is going to guide our management, not a pulse. And we'll get into more detail in that in just a bit. So next, regarding pathophys, we're going to touch upon two theories that are more tailored to us than ACLS is, and that's the 3 and 3 rule and the wide versus narrow theory. Now, the 3 and 3 rule is pretty straightforward in that it states that there are 3 main pathophysiological mechanisms that lead to PEA arrest. The first is severe hypovolemia. The second is pump failure. And third is circulatory obstruction, which can be further divided into 3 major causes: tension pneumothorax, cardiac tamponade, and massive PE. And along with this rule comes a couple of major caveats. The first being that some of the other classically listed causes of PEA, for example, hyper-K or an MI, tox causes or hypothermia, well, they probably act by exacerbating pump failure. Okay, and the second major caveat is that trauma can cause any of these 3. So keep that in mind as we go into our next theory, which is based on, well, if the rhythm strip is wide or narrow. And this cutoff is going to be 120 milliseconds. The assumption here is that a narrow rhythm is more likely due to either hypovolemia or a mechanical obstruction. And a wide rhythm is more likely due to a cardiac myocyte dysfunction resulting in pump failure. So let's think narrow mechanical obstruction, wide myocyte dysfunction. And we can see how this parallels to the 3 and 3 rule. So let's start with narrow. Remember, we just said it's more likely due to an obstruction. And this blockage is either going to prevent ventricular filling, so blood coming into the heart, or ventricular outflow, blood coming out of the heart. And already we could start thinking of some of those H&T words that can cause this. And the thought here is that narrow complex PEA is typically not due to poor myocardial performance. The pump itself isn't defective, but something obstructive is physically preventing it from doing what it's supposed to do. Therefore, with a narrow complex, our first instinct should be to find the obstruction and then to relieve it. So going back to the 3 and 3 rule we just discussed, what are some of the obstructive causes that can cause PEA? And that's massive PE, tamponade, and tension pneumothorax. So now start to think, what tool can we use at the bedside to evaluate for these? I think you all know the answer. Now compare this to wide. We assume that the cells of the pump itself are failing on us. This means that there's some process going on that's messing up the cardiac myocyte action potential, resulting in a wide complex. Okay? Now, cardiac myocyte cell membrane physiology, we have no time for that, but I want you to look at these 2 ions that keep popping up, sodium and potassium. Okay? So what are big 3 processes that can disrupt the cardiac action potential and result in a wide rhythm? Hyper-K, right, which is usually in conjunction with a severe acidosis. Some sort of sodium channel blockade. Think of your drugs like TCAs, diphenhydramine, type 1 antiarrhythmics, cocaine being a big one, or ischemia from a massive MI. So now think of which tools you can have readily available at the bedside to diagnose these. Now, you may be thinking these theories are far from perfect, and I'd say you're right? Neither of these theories have been validated, and neither of them are or will ever be the all-encompassing holy grail of PEA management. For one, they don't even cover all the causes of PEA. And of course they don't, but here's what they do. They emphasize potential etiologies that are rapidly reversible. For example, massive intracranial hemorrhage with herniation can cause up to 5% of cases of PEA. We are not reversing that. And as we just learned, I said to assume narrow complex PEA is due to a mechanical obstruction. But of course, mechanical causes can present with a wide QRS rhythm. These exceptions include patients with pre-existing bundle branch blocks. Well, it's kind of selfish of them, but it's true. Or an MI or a PE that can result in a new bundle branch block. And finally, the end of the road. Prolonged PEA can result in a wide agonal rhythm just before cardiac standstill. And again, there's no coming back from that. So it's not perfect, but what they do is they provide us with a more sophisticated and a more precise framework to go by. And now, last but not least, in the last couple of minutes, we're going to touch upon the basic concepts of a structured approach to PEA arrest. 3 simple steps. First, we start with our preparation in the pre-arrival phase. Next, at our first pause in chest compressions, we need to distinguish between true PEA and pseudo PEA. And the easiest way to determine this is performing a POCUS pulse check. Then, from the second pause on, we shift our focus to identifying and treating rapidly reversible causes. Let's start with pre-arrival. Have your ACLS crash cart meds ready, but also have a vasopressor infusion ready to go, running in the background during the entire resuscitation. Get your gear ready. That means ultrasound machine plugged in, gelled up, ready to go. Have your O2 sat, end tidal, A-line, everyone ready to go. Minimum 2 people dedicated just to CPR. And then last and far from least is assign someone only to get collateral info. It should be the only job they're doing, whether it's from EMS, family, chart search, because info obtained at the point of care is critical to a PEA resuscitation. The next step is determining perfusion status, and that's when we perform our POCUS pulse check. And this shouldn't take more than 5 seconds. If no pulse, resume CPR, give your AMPA-VEPI, your patient is not perfusing enough to create a pulse on sono. This is true cardiac arrest. But if we see a pulse, this is a profound shock state. You don't need to do compressions. Get an A-line if you can, titrate your pressor to 65, and then move on. And the third and final step is seeking out and treating reversible causes. And as your team's gaining collateral info, your first step is working your differential by determining if the initial rhythm was narrow or wide. And so if it's narrow, we're thinking hypovolemia, we're thinking some sort of obstruction. All roads lead to the same tool. Yes, that's ultrasound, because it can diagnose any of these at the point of care. And so if we see a huge RV, think massive PE. A big effusion and diastolic collapse, think tamponade. If there's a collapsed RV, but you don't see an effusion, you got to move to the chest or move down, complete a rush exam to get more clues to find that tension pneumothorax, or maybe that ruptured AAA or that ruptured ectopic pregnancy. So for narrow complex, our first tool to use is the ultrasound. Compared to wide, where we're trying to figure out what's messing up this cardiac action potential, right? And so our most useful tools here are going to be our EKG and our point of care VBG, because they can rapidly diagnose all of these: hyperkalemia, sodium channel blockade, or a massive MI. And so with that, if the rhythm is wide, push that bicarb, push that calcium until you gain more information. There's virtually no downside. So yes, in some sense, we're definitely still guessing, but this is a much more educated and calculated guess outside of ACLS. So instead of throwing the kitchen sink at our patients, let's use our tools, let's use our resources, let's use our abilities that are outside the scope of ACLS. All right, quick rapid wrap up of the major concepts one last time. The absence of a palpable pulse does not equal the absence of perfusion. Use the adjuncts we discussed. True PEA is real cardiac arrest. That's when we need to do chest compressions, epi. Prognosis is abysmal. Pseudo PEA, treat it like a profound state of shock. Titrate your vasopressor to 65. Look for those reversible causes. Prognosis, still pretty bad, but it's much better. Instead of random words that start with H and T, think of the big three pathophysiological mechanisms behind PEA: hypovolemia, obstruction, and myocyte dysfunction. And if you forget everything else, here are the four things that can really impact our approach. POCUS, to ID ephemeral pulse, to evaluate the heart and then do a rush exam if needed. VBG, to determine electrolyte abnormalities. EKG, to evaluate for ischemia or metabolic processes. And last but not least, the good old history and physical exam to focus on reversible causes. So the next time you take this dreaded call, you won't be thinking this, but you'll be thinking this instead. Thanks, everyone.
Dr. Steinberg, that was great. Now, while the office employees definitely tried to learn CPR at one point, it went horribly wrong for them. And this was certainly the best medical education that's come out of the conference room at Dunder Mifflin and Scranton. So thank you for that. I have a couple questions from the chat, if you can take them for us. First, this is from Nagar Mafi, who says, we only have a few seconds for pulse check during CPR. If we want to use end-tidal CO2 or pulse ox instead of the pulse check, how long does it take for us to see those changes?
Yeah, it's a great question. So I think in real life, everyone's still going to be checking for a pulse with their fingers, and these adjuncts will give you additional information. If you have good end-tidal CO2, it should be within seconds to get that feedback.
Okay, and then the second question is about the point of care ultrasound. This is from Janelle Lambert, who says, how do you really use this in practice? Are you going with the cardiac views versus the arterial pulsations for the pulse check? I've been seeing, she says, mostly people attempting to use the cardiac view with the ultrasound instead of getting these pulse checks with the actual pulse.
Yeah, that's a great question. And in the longer version of this, I would address this. But so with that, there's two things. It's stepwise. So the first thing, if you have one team and you have one ultrasound machine, that first step is to determine, is this true cardiac arrest, no perfusion, or is there some sort of perfusion? So the first step in the first pause of compressions, which is usually when EMS arrives, like 2 minutes later, is to use the linear probe, find the femoral, and see if there's a pulse. And then after that, you could put the ultrasound on the heart, either in the next pause of compressions, if it's still true cardiac arrest, or you can go immediately thereafter if you see a pulse.
All right. Thank you very much.
Thank you.
We're going to turn now to Dr. Jamie Hope, who's coming to us from Oakland University William Beaumont School of Medicine. She is a keynote speaker and an invited lecturer across the country on a variety of medical and health-related topics, and we are thrilled to have her joining us today. She has a special interest in physician wellness, resilience, stress management, and healthy habits. So it's really good that we have someone with her expertise to talk to us about a very traumatic topic next. She's talking to us about resuscitative hysterotomy. Dr. Hope.
Thank you so much for having me. Before I start my slides, I just want to express my appreciation in the opportunity to get to be here. I know with the pandemic, we had tons of changes, and on one hand, some people are feeling a little zoomed out, but in a lot of ways, it's been really beneficial. And the reason that you see me twice here on the panel is not because I have an evil twin. If I did, she could help me with laundry at least. But so I had this going on my computer and then also on my phone so I could do other things. And I found if I'm trying to multitask and do things that take some level of cognitive load, like email or even social media, I don't pay attention and I miss those awesome pearls that these great speakers are dropping. But I can hop on my Peloton and fold laundry and still learn. And I found as a squirmy, active, kinetic ER doc, I learn better if I'm moving. So there is some benefit. I absolutely miss in person. I'm looking forward to a both and in the future, because I think my residents would think it's a little weird if I drop and start doing sit-ups and planks in the back of lectures in between talks. Zoom, this whole thing also gave me permission to get an awesome stand-up desk and purchase an absurd number of plants for my office. So I didn't have to be depressed during the whole Zoom thing. So anyway, let's get started. Unfortunately, this is not the most lighthearted topic, but it's incredibly important. I teach a lot in pregnancy emergencies, so postpartum hemorrhage, coding of a pregnant patient, and then this specific focus is going to be on the resuscitative hysterotomy. And every time I teach this, I always worry that the shift gods, either the day before or the day I teach this, when I go in before after, are going to give me one just to prove that you've got to have the skills. So that is why it is incredibly important to practice. I worked yesterday evening. Instead, the shift gods gave me the scariest pediatric airway I have had in 15 years, for real. However, I work at one of the biggest, level 1 trauma centers in the country. Just I didn't get that. Could you, Siri, but oh, my watch is being weird. Sorry. Like many of you, very well resourced. So I was able to get PEM, the PICU doc, ENT, anesthesia, and everyone in the room was sweating. But I also work at a rural critical access hospital, which is a 3-bedroom ER, and the nearest doctor help is a 45-minute lights and sirens ambulance away. And that's why I love to teach these, high acuity, low occurrence type of procedures, so we know them like the back of our hand. So some things you can look up, right? You can look up some pressor doses, you can look up something about pancreatitis during a shift, but when someone's crashing in front of you, we don't have time. So making these really simplified cognitive tricks to help you remember these when you are at your most panicked and most scared makes such a difference. So let's get started. Yeah. And here we go. Sure. There. Okay. So this is when every second counts. And I love this quote. I read it in Never Split the Difference by Chris Voss, who is a former FBI hostage negotiator. So had to work in the same kind of high stress, high stakes environment like we do, where lives are truly on the line based on the decisions you make. So I remember this quote often: you don't rise to the occasion, you fall to your highest level of preparation, particularly in the most stressful situation. So like with a lateral canthotomy, we learned numb, crush, cut, cut. And with the crike, we learn knife, finger, bougie, tube. I want to offer you that same level of simplicity here today. So you'll see my slides are intentionally unfancy, very austere, very simple, so that when this possibly once in a career lifetime procedure happens in front of you, you will be ready. The other important thing is, because these are lower occurrence but such high acuity, it is really important to have spaced repetition. So I set aside time on my calendar once a month where I just go through these crashing, incredibly critical procedures. And then we do that with our residents as well, where we revisit it on a regular basis. But because maternal mortality is on the rise, women are having babies at older ages and with much unhealthier overall medical pictures, the odds of this occurring are actually going up. So there is a good chance that you will see this. And so when you're in the room, you will be the expert and that calm person who performs this procedure accurately. To be clear, I do not expect you to be calm on the inside. That sounds very frightening, but on the outside, you'll go through this procedure quickly and easily. The procedure itself is actually quite easy. But why do we even do this? Does anybody survive? And it makes such a difference. So we've got some older case series as well as some newer data coming through. But the survival, the infants that survive, and they're talking about neuro intact survival, some level of functioning to fully neuro intact, which makes a difference. And the huge key here is the vast majority of the survivors had this procedure performed within the first 5 minutes. So you don't have time to look it up. You have to know this, and that can make a huge difference for survival of the baby and of mom. Okay, so a couple things, just, timing of survival. Let's get into the procedure. So I broke this down just like numb, crush, cut for the lateral canthotomy and knife, finger, bougie tube for the crike. This is your ABCDs of resuscitative hysterotomy. So A is the appropriate patient selection. If they are 20 plus weeks and they have lost vitals and no ROSC within 4 minutes, four terrifying, very short minutes, this procedure is indicated, period, knife in your hand, go. Now, 20 weeks, we've got a fundus up at or above the umbilicus. Those measurements are a little bit imprecise, but if you see a gravid uterus at or above the umbilicus who is coding and has no ROSC, you cut. The most difficult part of this procedure is making that initial decision, which needs to be done. Then it's take a deep breath and just do the BCDs really easily. So that appropriate patient selection, there's oodles of evidence from ACOG and all those type of things. So B is your cut. So big, bold, bone to bone. big, bold bone-to-bone cut. You're going xiphoid to pubic symphysis. We want to get the abdomen open as much as possible. Depending on how much subcutaneous fat, you might need to take a few swipes at it, but you need to get through that tissue and open up the abdomen as quickly as possible. We are not trying to make this look pretty. We can fix this later when mom survives and is hugging her baby at home and is less concerned about the scar that she has on her abdomen. Okay, so we're going xiphoid to pubic symphysis, big, bold, bone to bone. All right, next step is cut the uterus. So you still have the scalpel in your hand and you look for the lower portion of the uterus. You want to cut that with your scalpel. Don't cut the baby. So you're going to get what I call the gush and rush. So if you make it through with your scalpel, you'll get the gush and rush of all of the fluid that that baby has been swimming in. That's how you know you're in. The next step is put the scalpel down. Now, there's a great case of a very successful resuscitative hysterotomy. Mom and baby both had great outcomes, but in the stress of the moment, the doctor continued to cut the uterus with the scalpel, kind of cut the baby stem to stern. They both survived, least of their concerns, but there's a safer way to do this. So you've already made your big, bold bone-to-bone cut, stem to stern, cut the uterus, gush and rush. Now put the scalpel down somewhere safe and get out your scissors. You're going to put your fingers in the hole that you created, put the scissors on top of your fingers, and let your fingers be the guide to keep it safe from cutting the baby, and cut the uterus wide open so you can get this baby out. So that's your gush and rush, okay? Deliver the baby. See, this procedure isn't as complicated as it sounds. Head first, of course, mind the cord. Just because all these other things are going on is not protective for things like a nuchal cord. So you still want to check, and we're doing everything we can to try and deliver this baby intact. So mind the cord, reduce any type of nuchal cord, clamp, cut. And in an ideal situation, in this very non-ideal patient scenario, we want to then hand the baby off to the NICU resuscitation team so they can go forward and resuscitate the baby while you can concentrate on mom. However, there are situations, if you're single coverage, where you need to also work on resuscitating the baby. You want to have the team continuing chest compressions on mom, anything you can do to help with the baby. At this point, if you can deliver the placenta, great. If not, the appropriate thing to do is to pack everything with sterile towels. You can even throw a staple or two in the belly to keep it closed. You still want to be able to open it to assess for bleeding. Throw a towel over it, continue to resuscitate the mom as appropriate per the algorithm for CPR, of course, and resuscitate the baby through the appropriate protocols. So this is another important thing. So this is the S, the little s. So you want to stop the bleeding, of course. So anything you need to do as you're packing that uterus, if you need to give it a little pressure, you want to do that. Make sure you are not inadvertently compressing either the aorta or the IVC, because that will worsen your resuscitation. So you're going to pack or press it carefully, of course, and the scalpel and scissors and the stones to do this procedure are really the only tools that you're going to need. Scalpel, scissors, stones. It's scary, but the procedure itself, as I've said, is very easy. Let's talk about some evidence-based medicine around this, because with all this going on, we are so used to doing a bunch of other stuff, assessments, things, cleaning. And in this situation, I'm going to tell you, don't waste time on these things. We're going to cut them completely out of this algorithm. They are not necessary. Prepping the skin. Now, I've seen this in situations, even someone throwing in codes and lines and stuff like that. The way that betadine works is it has to dry in order for it to be effective in reducing infections. So wet betadine does nothing except for make a mess. So I know you're going to be tempted to want to grab a bottle of betadine and hose it all over the skin and make a huge mess before you do this incredibly successful procedure. But it's not important. It's not going to work because you're not getting that drying time. So we're ignoring science. And now we've made a mess. If mom survives neuro intact and gets a little bit of an infection from you cutting the skin, great news. That's the least of her worries, because we can provide antibiotics. That is something that is very, very easy to treat relative to this very, very difficult to treat situation. So no prepping the skin, don't make a mess. This is an emergency procedure. As you can imagine, there's not time to obtain consent. This is covered in terms of legal, that this, even if the father of the baby is present or anything else, you do not have to ask, you don't have to discuss it. This is a go, 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 because again, as we mentioned, every second counts. Assuming mom has been getting excellent compressions from a witnessed arrest the entire downtime, the placenta is still getting inadequate perfusion, particularly if the uterus is compressing the IVC, and during the code, nobody is displacing it and allowing increased blood flow, or if they put lines below the diaphragm where you're going to get that compression and get, like an IO in an emergency situation, decreased fluid, decreased resuscitation. So this is not the time. We want to maximize our CPR, and we want to just move forward with this. So consent is not indicated, and you will be legally protected for doing this. Now, like the other speakers here, I am an ultrasound enthusiast. So this is one of the most rare occurrences in all of emergency medicine where I would absolutely, boldly, unequivocally say, do not drop a probe on this abdomen. If you have an appropriate patient greater than 20 weeks who is coding, who has not achieved ROSC, what you need to drop on that abdomen is a scalpel, not a probe. Ultrasound is not therapeutic and will not resuscitate this baby. The quicker you get them out, you can assess their health and perform whatever you need to do to resuscitate them. But taking that additional time, no matter how fast and amazing you are, is still time with the placenta and the baby are getting inadequate perfusion. So I apologize, ultrasound gods. This is the one time we don't need you. By all means, use it for all of the additional things, even using it after the delivery to assess mom, to assess baby, and by all means, the heart rates of everybody else in the room, because they will be also freaking out. Waiting for OBGYN. This is an us procedure. They can also do it, but this is an us procedure. So waiting for them to come down, we have that fear. We feel like we need the permission, or this is their area of expertise. I wouldn't call OBGYN to do a crike. It'd be nice if we had some airway folks, but this is our wheelhouse. This is our lane. This is part of our resuscitation skill set. By all means, call them, because at some point they're going to have to put this person back together. That is definitely outside of my wheelhouse. I could suture it up, but it's not going to look as good. Then they'll see if they need to do anything else, whether a hysterectomy is indicated. That is the downstream medicine, but don't wait for them. If you have somebody available, to call them and let them know we're doing a resuscitative hysterotomy. That will usually get them to drop their coffee and run as quick as possible, but the procedure should be started or completed by the time they get there, depending on how big your hospital is. And this procedure is an anywhere procedure. Just like it's an us procedure, it's an anywhere procedure. This is something that would be indicated to perform in the field. Now, I don't know about you, I don't spend a ton of time in the field, and that sounds extra terrifying to not even have the staff there. But assuming, pandemic and dumpster fire aside, if you have short EMS transport times, they can be performing excellent CPR on mom. But if you know from your call ahead that she's already been down for more than 5 minutes, when they hit the door, you get the scalpel. This is not an OR procedure. We're not worried about it being clean. We're not worried about anything except for resuscitating the baby, resuscitating the mom. So again, this is, as you don't rise to the occasion, you fall to your highest level of preparation. So appropriate patient, greater than 20 weeks, CPR with no ROSC within 4 short minutes. Gear cut, big, bold, bone to bone. Big, bold, bone to bone. You're going to cut her wide open. And you're going to use that scalpel to cut the uterus, get your gush and rush, put the scalpel down. Cut the uterus, not the baby. It's the scissors you use for the uterus. Deliver the baby in the placenta, mind the cord, just like in any other delivery, and then stop the bleeding and continue the resuscitation of both. So, all right. Also, for the record, I hope none of us ever have to do this, but as I mentioned, the rates of maternal mortality from other causes are on the rise. Dissection is huge. More than a huge proportion of dissections in women under 40 are pregnancy related. There's increased risk. Cardiovascular death, medication deaths. We have older moms, sicker moms, diabetics. So this is a potential, and that's going to be part of our career. So I hope that helped give you a little bit of comfort and a quick mantra to fall back on if this ever comes through your door.
Thank you, Dr. Hope. Only an emergency physician, I think, would feel compelled to ask forgiveness from the ultrasound gods after suggesting that an ultrasound has no place in the specific procedures. I like that. And that was particularly important today with all of our ultrasound gods on the.
I know. I don't want them to smite me and send me one of these procedures. So,
Dr. Hope, I have a question for you from the audience. This is from Che, who asks, can the uterine incision be done vertically or horizontally?
No, so in this procedure, you want to just go straight up. This is a the incision with the scalpel, yes, that doesn't matter. Gush and rush and make your hole, whatever, that shape doesn't matter. And then when you cut the uterus with the scissors, you're going straight vertical.
Okay, so the majority of the cut for our purposes, both skin and uterus, is going to be a vertical cut.
Straight up and down, yep.
Okay, excellent. Well, thank you very much. With that, everyone, we are going to head right on time into our next break. So feel free to try to do some laundry while riding your Peloton this time, just like Dr. Hope does. Good luck with that. Please don't hurt yourself. And be sure to come back right at 11:10 for us to get started with our last section.
Won't even get pulled over in they new V. The good life, let's go on a living spree. They say the best things in life are free. The good life, it feel like Atlanta, it feel like LA, it feel like Miami, it feel like NY. Summertime shy. So I roll through good. Y'all pop the trunk, I pop the hood. Ferrari. And she got the goods, and she got that. I got to look sorry. Yo, it's got to be, cause I'm seasoned. Haters give me them salty looks. Lowry's 50 told me don't hear, switch the style up. And if they hate, then let them hate and watch the money pile up. The good life, I go for mine, I got to shine. Now throw your hands up in the sky. I go for mine, I got to shine. Now throw your hands up in the sky. I'ma get on the TV, mama. I'ma put down. Welcome to the good life. We'll be like the girls who ain't on TV cause they got more earth than the models. The good life. So keep it coming with the bottles. So she feel booze like she bombed at Apollo. The good life. It feel like Houston. It feel like Philly. It feel like DC. It feel like VA or the Bay or yay. Hey, this is the good life. Homie, tell me what's good. Why I only got a problem when you in the hood? Welcome to the good life. Like I'm new in the hood. The only thing I wish you. Welcome to the good life. He probably think he could, but I don't think he should. Welcome to the good life. 50 told me go ahead, switch the style up, and if they hate, then let them hate and watch the money pile up. The good life. I go for mine. Yeah, I got to shine. Now throw your hands up in the sky. I go for mine. I got to shine. Now throw your hands up in the sky. I'ma get on the TV, mama. I'ma put down. Have you ever popped champagne on a plane while getting some? She said I never seen snakes on a plane. Whether you broke or rich, you gotta get this. Having money's not everything that having it is. I was splurging on trips, but when I get my car back activated, I'm back to Vegas. Cause I always had a passion for flashing. Before I had it, I closed my eyes and imagined the good life. Better than the life I lived when I thought that I was gonna go crazy. And now my grandmama ain't the only girl calling me baby. If you feeling me now, then put your hands
Day and night, I toss and turn, I keep stressing my mind. I look for peace, but see I don't attain what I need for keeps this silly game we play. Now look at this, madness the magnet keeps attracting me. I try to run, but see I'm not that fast. I think I'm first, but surely finish last. Cause day and night, the lonely stoner seems to free his mind at night. He's all alone through the day and night. The lonely loner seems to free his mind at night. At night, day and night. The lonely stoner seems to free his mind at night. He's all alone, some things will never change. The lonely loner seems to free his mind at night. At night, hold the phone. The lonely stoner, Mr. Solo Dolo. He's on the move, can't seem to shake the shade. Within his dreams, he sees the life he made. The pain is deep. A silent sleeper, you won't hear a peep. The girl he wants don't seem to want him to. It seems the feelings that she had her through. Cause day and night, the lonely stoner seems to free his mind at night. He's all alone through the day and night. The lonely loner seems to free his mind at night. At night, day and night. The lonely stoner seems to free his mind at night. He's all alone, some things will never change. The lonely loner seems to free his mind at night. At night, slow mo. When the tempo slows up and creates that new. He seems alive though he is feeling blue. The sun is shining, man, he's super cool. The lonely nights, they fade away, he slips into his white Nikes. He smokes a clip and then he's on the way. To free his mind and searcher, to free his mind and searcher, to free his mind and searcher. Day and night, the lonely stoner seems to free his mind at night. He's all alone through the day and night. The lonely loner seems to free his mind at night. At night, day and night. The lonely stoner seems to free his mind at night. He's all alone, some things will never change. The lonely loner seems to free his mind at night. At night. At night.
Status, grind all day, Cleveland status, grind all night. Cleveland status, grind all day, Cleveland status, grind all night.
like an oven. I need some loving. And baby, I can't hold it much longer. It's getting stronger and stronger. And when I get that feeling, I want sexual healing. Sexual healing. Oh, baby.
faster? I can do anything. I can do anything.
Here we go.
Neutron, proton, mass effect, lyrical oxidation, your irrelevant mass spectrograph, your electron volt, atomic energy erupting as I get all open on betatrons, gamma rays, thermal cracking, cyclotron, any and every mic you're on, transuranium, if y'all was uranium, molecule spontaneous combustion, pow! Law of definite proportion, gain, ink, weight, I'm every element around. Lead, gold, tin, iron, platinum, zinc. When I rap, you think iodine, nitrate, activate. Like uranium, the only difference is I transmit sound. Balance with some balance, then you add a little talent in. Careful, careful with those ingredients. They can explode and blow up if you drop them and they hit the ground. Let it blow, yo, just let it go. Get back. CaOH2 lime water, solution of calcium hydroxide. Slaughtered it. CaO lime will make bleach powder. Galvanic metal beats stomp out louder. Dry ice, CO square refrigerant. NO2 makes you laugh. It's laughing gas used by a dentist. I'm muriatic acid glue. I'm like oil of vitriol. The king of chemicals, energy, heat, gas, weight, all your mass. Chemical change, ice point, melt all your raps. Atomic weight, volt shocks when you call we land. Fillable gas, keep going way beyond. Biage, ammonia, with buzzing, fill the ambiance. A diabatic process ought to calm your ass. After I warm your ass, I give you sodium silicate, NO2, S103, a water glass. Borax flux, you're full of brimstone, sulfur, boracic acid, hip-hop preserver. CO2 could never put away the fire. Style aromas is scientific. The lyrical views would be connected to teach you chemical calisthenics. The theory is that all matter is composed of at least three fundamental particles: protons, electrons, neutrons. Proton is charged positive. By now you guessed electrons are probably negatively charged. Neutrons don't follow either. Neutral in the middle. Only no apologies. Centered, unmoved by yin and yang ideologies. Neutron bombs, arms, electron theory. Cosmic musical radioactivity. Different points and joints within infinity. Oxygen and hydrogen alive within all types of energy. 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 Inside a world, inside a world, inside a universe, inside of me existing, although I can't see it. Hydrocarbon, nitrogen cycle, ionization, heavier than electromotive metals that weigh over a ton. This has been a chemist, black delicious creation. Clean out your desk, put your papers away, cause class is almost done.
All aboard for the night train.
This is chemistry plus calisthenics. Some calcium plus potassium, magnesium, use paper of sodium, sulfate, your solvent, chloroform remedy from the north, glycerin, purest form, titanium, brain is blown away out when this nucleus out of water, vibration forming underneath of some bleachers and teachers and legions are equal to pieces of media, eager to be here and eager to see it. I know what I'm going, I'm thinking, I'm bringing, I'm shooting, I'm rolling, I'm thinking, I'm rolling, I'm cooking a potion. Yeah! Go!
I've always been the one to say the first goodbye. Had to love and lose 100 million times. Had to get it wrong to know just what I like. Now I'm falling. You say my name like I have never heard before. I'm indecisive, but this time I know for sure. I hope I'm not the only one that feels it all. Are you falling? Center of attention, you know you can get whatever you want from me. Whenever you want it, baby. It's you and my reflection. I'm afraid of all the things it could do to me. If I would've known it, baby, I would've stayed at home. Cause I was doing better alone. But when you said hello, I knew that was the end of it all. I should've stayed at home. Cause now there ain't no letting you go. Am I falling in love with the one that could break my heart? Oh no, I was doing better alone. But when you said hello, I knew that was the end of it all. I should've stayed at home. Cause now there ain't no letting you go. Am I falling in love with the one that could break my heart? I wonder when you go if I stay on your mind. Two can play that game, but you win me every time. Everyone before you was reflection. You know you can get whatever you want from me. Whenever you want it, baby. It's you in my reflection. I'm afraid of all the things it could do to me.
Oh man, how sad it is to leave in the middle of Dua Lipa. All right, everybody, welcome back to the last segment of our spectacular conference today. We just have a couple of quick announcements that I'd like to share with you before we move on to the final segment. The first is we are so fortunate to have a really amazing fellowship opportunity with the ALLNYC group. Basically, every year in the fall, we draw out some applications from the several hundred residents that we have in our sort of under our purview. And you get to apply to the fellowship, and these fine people, Dr. Brian Sumner, Dr. Janelle Lambert, and Dr. Riddhi Desai, get to participate alongside us, speak at a conference, and really get fine mentorship through a whole year to help sort of take them to the next level in their medical education leadership. So keep your eyes, first of all, welcome our 3 fellows for this year. And keep your eyes open in the fall for upcoming opportunities. Again, another reminder about our spectacular basketball tournament that's going to happen in June, early June, June 2nd in Brooklyn Bridge Park. Sign your team up and let's kick it old school and see who are the kings and queens of the courts. And again, please stop by our website for events, updates, and all good things that are coming your way. Okay, so now that we've all flexed our brains a little bit this morning, I'd like to invite everybody to enjoy another episode of Curbsides with Dr. Duncan Grossman. He is... he's going to share with us some
enjoy spackling, I guess.
Oh, hell yeah, baby. I can't wait. I brought a spray gun for painting. We're going all out on my birthday. Hey, my name is Haney Malamet, just a guy who does some critical care and emergency medicine. All I want to tell people is just remember that they got to know the ventilator very, very well. Don't outsource this to respiratory. Respiratory is going to be a good ally for you. They're going to help you to learn the ventilator. When they're around, I certainly work with them. But the answer to the problem should never be just ask respiratory. You got to know your vents if you're going to be an awesome emergency medicine physician.
Haney, I think for me personally, the most common vent alarm that I tend to see in the emergency department is this high pressure, high peak pressure alarm. What does that mean? What is the vent trying to tell me in that scenario?
Peak pressure by itself just tells you that the overall pressure in the system is high. It doesn't help you to narrow things down. Peak pressure, just remember, is a combination of all the forces of the ventilator when it's pushing air into the person's lungs. So again, that's the resistance of airflow through the tube, endotracheal tube, the trachea tube, the bronchioles, the terminal bronchioles, and it's also the forces of how stiff the lungs are, if there's any fluid around the lungs, if there's any lack of compliance of the chest wall. That's a summation. The next question you should ask is, what's the plateau pressure? You need to find that plateau pressure next to help you to whittle things down. So when someone tells me, Haney, the peak pressure is high, my next question is, well, what's the plateau pressure? I want everyone to walk away from this saying high peak pressures, your reflex, your knee-jerk response should always be, what's the plateau? Don't ever act on a peak pressure just by itself. The plateau pressure is when you ask the vent, hey, stop flow in the system. That takes out resistance. All you have left is the compliance of the lung, which we assume is the only problem, but don't forget that chest wall can also be the problem as well.
How do I determine the plateau pressure?
Every ventilator has its own nuance to it. So I always, when I start a new job, I ask the respiratory therapist, hey, this vent over here, show me how to do the inspiratory hold. But that's essentially what you're going to be doing. So the vent delivers a breath and then you pause airflow. So you hold airflow, you close the valve on that vent. And now you're just seeing what the static pressure is static because there's no airflow. Every machine will have its own nuanced way of doing it. And some machines actually determine that on a breath by breath. You just have to find the menu where that's listed out.
So if I get called into the resus bay after I just intubated a patient and the vent starts beeping and I'm getting a high peak pressure alarm, I did an inspiratory hold, there is a high plateau pressure, how do I approach this patient?
High peak, high plateau, there's a problem with the compliance of the lungs. So I start to think about that realm of things. What could have caused suddenly to be a change? If someone recently tried to put a central line in, did that person get a pneumothorax? That would cause a high plateau pressure because now you're ventilating a stiff lung. If the person got fluid after fluid bolus after fluid bolus, now their lungs really get soggy and bogged down with fluid. Now that lung is stiff, it's difficult to ventilate. Always a low threshold to take the ultrasound in the room. I'll look for the pleural spaces. Is there a big pleural effusion that's causing that lung to get constricted down to that thorax that's not expanding? If the peak pressure is high and the plateau pressure is low, then I'm in the resistance box. Work your way down the tube. So you think about the ventilator. Is there a kink in the tubing of the ventilator? Is there a kink in the tube? Maybe that patient's not adequately, doesn't have enough analgesia, which is a common thing in the emergency department, and they're biting down on that tube. The tube got kinked in the back of the throat. So try to take one of those suction catheters, pass it through, and then think all the way down. Is there bronchoconstriction? Is there a mucus plug in there? Once you go down that rhythm like that, you'll figure out where the resistance is happening. But again, high peak, high plateau, it's a problem of compliance. It's the lungs. High peak, low plateau or normal plateau, then you're thinking it's a problem of the resistance in the tubes.
How about the opposite alarm? How about the low pressure, low ventilation alarms?
So low pressure means that there's a leak somewhere in the system. And for those types of things, I'll think about if the endotracheal tube has migrated above the cords and, now the tube is inflated or the cuff is inflated, but air is getting around. It could be that the cuff is ruptured and there's a low pressure that way. You'd want to look at your inspiratory and expiratory volumes. It's a quick little trick you could do at the bedside. So what I do is I go when I have a low pressure alarm, I look at the inspiratory volume delivered and we'll pick a random tile volume of 400. So this person we picked is getting an inspiration of 400. You've determined that. You've set that on the ventilator. You have to be sure that the expiratory volume, the volume that's detected by the ventilator, is 400. If it's less than 400, likely with the low pressure alarm, then there's a leak somewhere in the system because 400 is getting out of the patient, but it's just not getting back into the tube getting detected by the ventilator. There's a leak in the system.
Thank you so much. I really appreciate it.
You're very welcome.
Wow, I absolutely love those little videos. So thank you, Dr. Grossman, for bringing those to us. I'm very happy to be introducing our next speaker. This is Dr. Chris Hicks, coming to us all the way from Toronto, Canada, where he works at St. Michael's Hospital as a trauma team leader, which is something a little different than we have in the United States, but it means he's a trauma expert. He's a simulation and resuscitation fellowship director and a research scientist. He's a well-known national and international speaker. I'm sure in keeping with the theme of the day, he is a lover of ultrasound, but I know that he is a lover of dogs. Dr. Hicks is here to talk about penetrating neck injuries. Dr. Hicks.
Hi, everyone. Thank you, Jenny, for that intro. And thank you all for having me. I'm looking to share my screen as it is 2021. And I think I'm doing that now. Let me know if this looks weird or if it doesn't look like anything at all, but I think we're good to go. Cool. So thanks for that intro. Hi, everyone from Toronto, Canada. I think when people think about the Wu-Tang Clan, and bear with me here because I'm going to come back to neck trauma in a second. I think the general impulse is, a bunch of rough and tumble comic book nerds from Staten Island, 10304, Killer Hills, Shaolin, etc., as we do. If you really unpack a lot of the lyrics in the Wu-Tang Clan's work, I think you can find a lot of important public health messages, and perhaps none so poignant as in their opus, Protect Your Neck. And I think I'll leave it to you to review the lyrics and the messages therein on your own schedule. But my take is that there is a lot of relevance there towards the nuanced management of penetrating neck injuries. And so with the spirit of the Wu-Tang Clan clearly in focus, we're going to talk through what I think is a bit more of a practical and perhaps somewhat more or even less nuanced and easier to implement approach to critical penetrating neck injuries. So this was a case we had at our hospital maybe about a year or so ago now. And it was an unfortunate case of an elderly patient who tried to take his own life with a self-inflicted slash injury to the neck, slash as opposed to stab. That's my hand there trying to do two things. You can't see the shaking because it's a static photograph, but this was a pretty high intensity resuscitation. And I've got one finger over a pretty prominent hole in the trachea, which was bubbling away at the time. And another one trying to stop one of the last bleeders that we were trying to identify before we moved the patient out of the trauma room. So the case, again, was an elderly man who presented with no palpable blood pressure. He was altered. He had no IV access. He was, for the time being, protecting his airway and had a reasonable oxygen saturation, but obviously had the finding in view as kind of our direct priority. And we talk a lot about, in resuscitation in general and in trauma in particular, the importance of prioritizing injury. Well, that only goes so far. And in some circumstances, you really have several immediate priorities that take precedence all at the same time. In other words, certain things you can't put off in favor of other things. And I would say that neck trauma, in this case in particular, and other ones like it, are a great example of really how you have two immediate life-threatening priorities and you really can't sort of settle on one over the other. You really have to figure out a way to co-manage. And this isn't really a talk on the team dynamics of resuscitation, although we'll touch on it. But if there was ever an argument for mini teams or sub teams, semi-anonymous teams working independently towards a shared resuscitation goal, this is it, by way of an airway team and a circulation team. And we'll touch a little bit on what that looks like. But I think one of the challenges here is really figuring out how to manage an airway crisis at the same time as a circulatory crisis, given that all the anatomy is jumbled together. It's not like this patient has a bleeding leg injury and an airway problem. All of their problems are kind of concentrated in the same space, and you need a coherent approach to figure out how to work through all of that. So let's start with circulation. The Wu-Tang gave us so many things, including a wonderful binary color scheme like black and yellow, and penetrating neck trauma presenting all of these clinical dyads works well from a color point of view too. So one of my first hangups, and I would say this is kind of a hangup I have with trauma patients in general, is the impetus to slap a collar and a backboard on every trauma patient and make them lie flat. We had a case like this in our department a few years back where a patient with a facial smash was sitting up when they came into the department, appropriately enough, trying to manage their facial bleeding and protect their own airway. They were made to lie down and were submitted to a C-collar, at which point they vomited. They required intubation. They couldn't be intubated, and they ended up with a cricothyrotomy in the emergency department. The incidence of cervical spine injury and penetrating neck, both stab wounds and penetrating, is actually quite low, probably less than 1%. And even if you do have it, in the case of penetrating neck trauma in particular, the spine is already injured. A gunshot wound will transect the spinal cord. There's probably very little you can do to further protect the spine apart from try to keep the head still to some degree. But certainly a C-collar doesn't accomplish that goal in particular. And it's not a neutral proposition. You can look at reviews of the utility of mobilizing the C-spine and penetrating neck injuries and find that the increase of complications is actually higher. And it's not really hard to imagine why. Again, the patient is supine. They're having a harder time protecting their airway. They have a harder time with oxygenation and ventilation. The collar does, in many ways, cover up injuries. And unless you're deliberate about taking it off and inspecting, you may miss clinically relevant injuries. In this particular scenario, and in others like it, I think it's important that the patient's allowed to assume the position of most comfort. And if that means, in your own mind, sacrificing the stability of a C-spine injury, which I think we can agree is comparatively rare, then so be it, because the more pressing issue is worsening airway status and more challenges related to immediate hemorrhage control. So this sort of scenario should be outlawed, and C-collars for penetrating injuries in general really are not indicated. and they're probably harmful. This is the only slide on anatomy. This is a cross section of the neck. I think really two messages should jump out here. One, it's an awfully complicated region of anatomy. And two, when you're talking about penetrating neck injuries, the platysma gets a lot of play. And we'll touch on why that's perhaps less relevant now. But in the past, certainly the notion of a penetrating platysmal injury has or had relevance in terms of next steps in management. And that's all fine. But I think the other structure I'd like to draw your attention to is a sternocleidomastoid. The sternocleidomastoid is in very close proximity to the carotid bundle. And I think that's important to pay attention to, in particular when you're managing injuries like this, because if you can see SCM, and in particular, if you can appreciate that SCM has been transected and you've got a sick patient with a lot of bleeding, even if you can't visualize it directly, you have to be very concerned about a jugular or carotid injury. So platysma violation is one thing, but try and pay attention to the anatomy of structures adjacent to major vascular and neurologic structures, particularly those relevant to the carotid bundle and the carotid sheath. What you can see here in sort of the upper corner of the white box is the proximal section of SCM. So sternocleidomastoid in this case was transected, and even though we couldn't view the vessels directly, you had to assume that there was potential major vessel and major vascular injury associated with how this patient was presenting. So really, everything about initial steps in management, virtually everything, in fact, the focus of your primary survey in patients like this is a modification of the ABCs to look specifically for signs of hard and soft vascular injury. I'm leaving aside aerodigestive injury. That's a somewhat separate but related topic. Your primary survey, when it comes to circulation in particular, should be looking for and scrutinizing very carefully for hard signs of vascular injury. Now, some of these are more objective and some of them are more subjective. What you define as massive hemorrhage, I guess, depends on your viewpoint. But certainly massive hemorrhage, refractory shock, I think in patients that don't respond to your initial volume resuscitation, you can probably classify those either as refractory or as non or transient responders, to use a more sort of clinically useful vernacular. An expanding or pulsatile hematoma, a central neurologic deficit, again, as an indicator of a vascular injury, not as a neurologic injury, or a pulse deficit. If any of those are present, you have a 90% chance, a 9 in 10 chance of a surgically relevant, clinically relevant vascular injury to the neck. And those patients are much more likely to need emergent and immediate surgical control and surgical exploration. They're certainly much more likely to need fairly immediate airway control. And in a hospital like ours, where we have a tiered trauma system, where unless you're a tier 1 trauma, a trauma surgeon isn't directly involved in the care of the patient necessarily. If you're not doing anything else, you're at least having a conversation in the early stages of resuscitation with your trauma surgery team about the necessity of taking this patient directly from your resuscitation room to the operating room. So the presence of those hard findings really do dictate in the early going very immediate next steps in management. And that's why I think they're so important, because they dictate what you do next. They're not just findings for the sake of findings. They're very management relevant. On the other side of things, the soft findings, again, a little bit more subjective, but if you have bleeding, and I would say minor bleeding is bleeding that can be controlled with direct pressure by some mechanism, a hematoma that's non-expanding, or wounds that are in proximity to things that are important that may imply vascular injury, but you're not seeing direct evidence of. Those you have a bit more time for, you have a little bit more time to think, a little bit more time to manage, and it indicates different steps and different next steps in care, specifically a CTA, which we'll touch on in a moment. I just want to remind everyone, when we talk about pulse deficits, this is one thing that I see often forgotten about. So if you have a major injury to the right side of the neck, one of the things that you ought to be checking is the pulse in the right upper extremity. I'm less concerned about blood pressure measures in both arms. I think more a pulse deficit. If you imagine a patient who's got an aortic dissection, for example, and you're appreciating a deficit in the pulse or a difference from one upper extremity to the other, that's a clinically relevant finding. It's true in penetrating neck trauma as well. Again, blood pressure is less relevant, but if you can subjectively appreciate, say, an absent pulse in the right upper extremity and one that's robust to the left, that's an important hard finding. And it's one that's relatively easily missed. If you are measuring blood pressure on both sides, the other thing that can trip you up here is you're measuring blood pressure on the side that's ipsilateral to the injury. And if you have a vascular injury, you may get a reading of 50 on 30 on the affected side and something that looks comparatively normal on the unaffected side. So if you're doing art-line cannulation, and I would argue probably femoral is a better option here, but if for whatever reason you're doing radial outline cannulation, or if you're doing non-invasive blood pressure measurements, most safe, I think, in terms of accuracy is to do it on the unaffected side. The reason for that is if you get a falsely low reading, just like an aortic dissection, you may be prone to over-resuscitating. And in the case of a vascular injury, if you're pumping in tons of blood product to a patient that's actively bleeding, we know that that's associated with harm and increased mortality, so something to avoid. At the very least, put a hand on both upper extremity pulses. If there's an appreciable difference, that's a clinically relevant finding, both in terms of heart injury and can, to some degree, guide your resuscitation targets moving forward. Now, with all respect to Ruben and his virtual background, this is not the time to stand around gawking at injuries. And this is one of my hangups with penetrating neck trauma in particular. Never mind the fact that this is a bunch of white dudes standing around a patient, which really never did much good for anyone except, say, subjugation of the masses. But unless you want your patient to look like the dude lying on the table, resist the impulse to start looking at the neck wound over and over and over again. And I see this all the time. Somebody's applying pressure to the neck. Someone walks into the room, they take the pressure off. Oh, look at that. That's kind of cool. Wow, that's really squirting. Pressure goes back on. Somebody else walks in, they do the same thing, the same thing, the same thing. Avoid the impetus or the impulse to gawk at a neck injury. At the very least, when a patient rolls in, continue applying direct pressure to the wound and get yourself set up. There's absolutely no point in opening up and revealing a neck injury if you're not set up to do anything about it. So that means patient positioning, lighting, equipment, and backup equipment, personnel. There's really no sense in gawking if you're not really prepared to take the next step, which is management. So don't peek, don't gawk. Direct pressure is easy to do wrong. And what I commonly see here is just bundles of gauze shoved into the neck and then somebody applying pressure with a couple of hands. Really the most useful way, provided you can identify some discrete site of bleeding, is with a relatively and comparatively small bundle of gauze and a couple of fingers, providing much more direct force over the area that you think is bleeding. A field mechanism that can sometimes work, and sometimes the sort of conceivably one good reason for a C-collar is a collar with a bunch of gauze bundled up on top. And then the collar applied over top of that. Again, that's something that's used in the field and you may see from time to time as a temporizing measure, but it probably doesn't provide enough direct pressure to really stay a vascular injury like the ones that we're most concerned about. So consider your two fingers as perhaps your best tool for direct pressure. If that's not working, two things. One, you've probably identified hard findings for vascular injury. Two, you can do other things like Foley catheter tamponade. And we did this for a patient a couple of months ago and it worked really well. Not because direct pressure wasn't working, but because we had to continue doing direct pressure as the patient was getting ready to go off to the operating room and everyone was just getting tired of pressing on the neck. So in this circumstance, you could take 1 or 2 Foley catheters, an 18, a 20. Ideally, you're filling the balloon with sterile water or saline, not air, to avoid the theoretical risk of an air embolus. It works better for stab wounds to the neck. In a patient like ours with a slash, it really isn't effective. And your goal here is to get the balloon down adjacent to where you think the injury is. You don't have to know where it is. You are not trying to feed the balloon directly into the injury itself. You're just trying to get it adjacent to where you think the bleeding is. And then you bring up the balloon. You can close the wound around it and then clamp proximally to avoid any migration. And if that's not good enough, you can put a second one closer to the entry point of the wound. So 1 or 2 balloons might be required in this scenario before closing the skin. And in the case that I'm thinking about, again, it just sort of freed up the team to not have to apply direct pressure to the patient's neck and facilitated transport. But it certainly is an alternate in these sort of deep stab wounds to the neck where you can't really appreciate the cavity. You don't always know where to apply direct pressure. So keep that as a tool in your toolbox as well. And then finally, although I think blind tie-offs are certainly a bad idea in an area of anatomy as complicated as this one. If you can see a vessel that's bleeding, feel free to tie it over. In this case, a lot of the arterial bleeding was coming from branches of the facial artery, and they were relatively easily identified. And once we tied them off, we got fairly good purchase on bleeding. This can be done with an absorbable suture like Vicryl. You can do it as a horizontal mattress suture. You can do it as a figure of 8 stitch. It doesn't have to be fancy. It's just a temporizing step. But in this case, you can appreciate 2 tie-offs over 2 small arteries. Again, we can see where the vessels were. We were confident that there weren't any adjacencies that we needed to worry about. And so we tied them off, and it gave us a fair bit of immediate hemorrhage control. So that's not illegal. You just want to avoid tying off empty spaces where you're not sure where your suture needle is pointed towards. As always, the principles of hemostatic resuscitation apply here, and this is not really a talk on resuscitation targets, except to say in vascular injuries in patients who are bleeding profusely, you do not want to over-resuscitate, so you want to try and keep up. And related to the conversation you heard previously on perfusion, you're trying to ensure some adequate degree of perfusion, sufficient enough for the patient to mentate or have peripheral or central pulses and get them off to their next stage in care. Over-resuscitation in the case of a major vascular injury could be very detrimental. Now, it might sound a little weird to you. You haven't heard me talk about the zones of the neck at all, and that's, I think, quite deliberate. And in fact, the zone that's being pushed a fair bit more frequently in contemporary neck trauma management is this no zone concept, which is to say that at least from the trauma room point of view, what zone of the neck is injured is really, really less relevant in terms of next steps in care. What really matters is the hard and the soft findings. And the reason for that, again, is that they're linked to next steps in clinical care. With hard findings, the need for active resuscitation is typically present. The need for active airway management is typically present, and you almost always have to operatively explore. We used to say that with platysma violations in zone 2, that those patients all needed mandatory exploration as well, but that was pre-CTA era, and CTA these days is a very good test to identify that. So it's not true that a zone 2 neck injury needs to go to the OR. And more commonly in our shop, we'll have a conversation with our trauma surgeons, but more often than not in patients with soft findings, they'll go off for a CTA. And if they don't have any major evidence of aerodigestive or vascular injury, that's essentially it. So the zones don't dictate quite as much in terms of initial management, which is why you don't hear folks talk about them quite as much. Now, in the last couple of minutes, this is not an airway talk, but I just want to talk about a general approach. Again, team management is important, and sub-team management, I think, is in particular important here. For this case, we had 2 airway teams. We had our team from above and our team prepared for front of neck access. At the very least, in the early stages, you're trying to not to overventilate. BVM ventilation and aggressive BVM ventilation in particular is not a good idea. If you have a hole in the trachea, you're going to blow air and distort the soft tissues even further. You do what you have to do, but just a reminder to be very careful of that. And the first question you're asking yourself in terms of an approach is the anatomy distorted or is it normal? We had a case from a few years ago now of a penetrating ballistic injury to the neck that was through and through with a massive hematoma, and that patient's trachea was pushed way to the side by that hematoma. We tried from above, and we probably shouldn't have because we had absolutely no view. And in that scenario, it would have just been safer and more efficient to go front of neck access by way of a cricothyrotomy. If the neck gives you a hole, say thank you to the trauma gods and take it. In other words, if there's a big hole in the trachea, just stick it into a trachea tube through that. That's probably your best option in a distorted airway scenario. But bear in mind at the very least that you have major distortion. And I would say things like a large hematoma, disruption of the trachea, displacement of the major vascular or airway structures is a good indication that you will need to do front of neck access as your first attempt. You don't even necessarily need to prep to go from above. If the anatomy is relatively normal, then you are, I think, safer to do something like a rapid sequence induction or an awake intubation, appreciating that topicalization in a bloody airway is going to be very challenging. And in that scenario, doing it with a double setup. So if you're doing an RSI, for example, you have a team that's identified the landmarks and they're ready to move on a surgical approach, a cricothyrotomy in particular, if that doesn't succeed. And since I'm up in Canada, I have to coin the phrase and talk about the double-double, which is a double setup for airway with a double setup for approach from above, including video laryngoscopy and video bronchoscopy. So the double-double means you are using a video laryngoscope to guide your bronchoscopic attempted intubation. And you also have the second double, which is the double setup for front of neck access. And then that's, in fact, for the patient that we're referring to, what we did. Now, in a pinch, the poor person's approach would be a bougie and just a smaller tube, and I think that's perfectly fine. You got a bougie in, you got a smaller tube gently over top of that. If you're not comfortable with, if you don't have the tools at hand, if you don't have help who can come and back you up, that's a perfectly acceptable approach. This is a 1-minute video from Laura Duggan where she demonstrates the double-double. So what you're going to see here is Laura directing her attention and her team's attention to the screen number 1 which is the glide scope screen. And what she's doing here, and Ruben can comment on this as well, but she's getting herself a view of the cords, and you can see there's some blood in the airway. This was a penetrating neck injury. And now you can appreciate the video bronchoscope going below the cords. Next, your eyes go to screen number 2, which is the screen for the bronchoscope at the top of the field. And now this is both diagnostic and therapeutic. In other words, you are looking at and trying to appreciate things like partial tracheal transection. You are appreciating that you are in the airway by way of appreciating the tracheal rings. And the therapeutic part, of course, is you can pass an endotracheal tube over top of that. So this is what we mean by the double-double, the video laryngoscopy and the video bronchoscopy, plus the double setup for an immediate surgical airway as needed. If there was ever a time to practice mental rehearsal, I think this is a scenario that suits it. This is going to be a challenging thing when it comes up for the first time. So that's not the time to first think about it. And mental rehearsal can be effective both for the haptic and procedural based elements of this, plus the team dynamics, which are complex. Again, in our case, we had a vascular team managing the vascular injury. We had a team intubating from above, and we had a front of neck access team. All of those had to be coordinated, and it gets very, very tricky. So think about your local resources. Think about what you do in that situation, and take some time to think through it in your head before you ever encounter the situation. And think of the Wu-Tang Clan, because they're here to help. Remember, hard versus soft findings. They dictate everything. The zones are less relevant than you might imagine. CTA has by and large replaced mandatory exploration for penetrating neck injuries that violate the platysma. And think about the double-double, which is your video laryngoscopy, video bronchoscopy with a double setup for front of neck access. That is me, and thank you very much.
Wow, thank you, Dr. Hicks. Certainly unforgettable case presentation, unforgettable double-double. For those of us who've had the luxury of a daily double-double. And that video was absolutely wild. Thank you so much. We do have a question from the Q&A. Oh, it's from Dr. Bonnie Barron. It's just it's a comment that she mentions that it's important to mention that the CTA alone is not sensitive enough to exclude aerodigestive injuries. So that's a really good point. The CTA is a sensitive test for vascular injuries, but not sensitive enough for aerodigestive injuries. Okay, thank you so much, Dr. Hicks. That was spectacular. We are drawing to the edge of our conference, and I am pleased to invite Dr. Shahrukh Hassan to join us next. Speaking of the Wu-Tang Clan and speaking of Staten Island, Dr. Hassan did her medical school training in New York City. She then completed her residency training at SIUH on Staten Island, where she was a chief resident and became an attending physician, where she currently is the clerkship director. Along with creating innovative and novel approaches to medical education, Dr. Hassan is in search of the finest steakhouse. Now, I know that this can be a particularly hot topic of debate. I know I have a very hard opinion on this, but if anybody has some comments or suggestions, I'm sure she'll be willing to take them in the comments. Thank you so much, Dr. Hassan, take it away.
Thanks, Sally. Yes, definitely let me know of any steakhouses. Thank you so much for having me here today. And thank you for that lovely introduction. And thank you for the Wu-Tang intro, because that is a great leeway being from Staten Island, and definitely protect your neck. But I'm Shahrukh, I'm from Staten Island University Hospital. And before we begin, I just want all of you to take a look at this picture. So she's holding this laryngoscope blade, confident and poised. No, this isn't me. I typically don't hold a blade in my hand and have someone take a picture of me in a subway station or an alleyway. But this is how I'd like to envision all of you by the end of this lecture, as confident and poised as she is, because we're going to be talking about a particularly sick patient. We're going to be talking about intubating a GI bleeder. So what I want you to do for the next few seconds, these minutes, is envision yourself in each scenario and ask what it is you would do. What wouldn't you do? How would you manage this patient? Imagine yourself in the critical care area of your emergency department, working with that attending that you know as a black cloud. And there's just mayhem. You're taking care of all these sick patients you never thought you'd be seeing. So many things are happening at the same time. And if you work at Staten Island University Hospital, you'll know at some point that you're going to be taking care of someone from the mafia, particularly this patient. So for those of you who don't know who this is Gregory Scarpa. He was part of the mafia. True story, he had stomach pain, so he started taking aspirin thinking that aspirin would help his pain. He then ended up taking a bottle and suffered a major GI bleed. He's your patient today. He's pale, he's hypotensive, and he's extremely tachycardic. What I'd expect you to feel at this point is your heart is going to be beating very fast as this ends up happening in the next few seconds. There's blood vomiting everywhere, basins and buckets of blood around the bedside. So again, heart beating out of your chest, you're feeling palpitations, you're not sure what to do next. Because not only are you taking care of someone that's known as the Mad Reaper, but you have to know how to intubate this patient quickly within the next few minutes. You're not going to feel like this today. You're going to feel like that picture depicted, confident and poised. So take a deep breath. And remember, as with anything and with all these lectures, the one thing they've been teaching is that preparation is key. That's why you're all here today, to learn and gain insight on how to prepare for these critical situations, these scary situations. All right, so what's the first thing? You guys have all mastered this, so place your PPE on, and next get medications on board early. So many things are going to be happening at the same time, but the reason why I want you guys to remember these two medications and starting them early is because they take time to work. They're both prokinetics, so they're going to help empty the stomach. It's going to be Reglan 10 milligrams IV and erythromycin 250 milligrams IV. In addition to helping to empty the stomach, the Reglan is going to act as an antiemetic, and it's going to increase that lower esophageal sphincter tone, which means less regurgitation of that blood. So remember, takes time to work, start them early. You also want to remember to resuscitate before you intubate. This is not the focus of this lecture. This is a lecture in itself, but I just want to spend a few seconds on this. This patient is going to be hemodynamically unstable. They're going to have a massive GI bleed. So more than fluids, you want to make sure you follow your massive transfusion protocol, get blood on board early. In addition, you want to make sure to have the pressors on the pump ready to go for after you intubate, including those push-dose pressors, which now you know how to make from that beautiful video earlier, because this patient is going to get hypotensive after you intubate. They're already hypotensive. So remember, preparation is key. The next important thing is the NG tube. Now, this is controversial. You want to limit regurgitation and aspiration, so some may avoid this, but I typically try to place the NG tube if I think it's possible. It makes sense, right? You're going to place this NG tube. It's going to continuously empty the stomach while it's on suction. It's going to remove that blood and allow you to have a better view. So try to place it if possible. And remember, it's not contraindicated in the esophageal varices. The other important thing is your positioning of your patient in your intubation, which was mentioned earlier in these lectures, specifically the bed up, head elevated position. So this is based on anesthesia literature. And what you want to do is have the external auditory meatus in line with your sternal notch. This is going to do a few things for you. One, you're going to have less dependent alveoli, which means you're going to have better pre-oxygenation. Two, you're going to have a longer apnea time, which means your O2 sats are going to be higher for a longer period of time. The other benefit of this is that if your patient has a lot of adipose tissue, this is going to offload that mass and allow you to get a better view of your glottis. So get that patient in the bed up, head elevated position at 30 degrees. If they start vomiting, put them in Trendelenburg to get the emesis out of the lungs. Hopefully by this point, your medications are kicking in and you could place your patient ready for intubation. All right, so you've got your prokinetics on board, you're resuscitating before you're intubating, you even placed an NG tube on suction, and you're positioning your patient. But what's in the money bag? What do you need for this intubation to make it successful? Well, we're going to talk about pre-oxygenation more, but remember to have high flow nasal cannula or your nasal cannula on blast, and if you can, a non-rebreather, so you pre-oxygenate well. The patient might be vomiting, so you may not want to put the non-rebreather yet, but if you can, put it on the patient. The other important thing is your bougie and your LMA, which we'll get to, and then your induction agents. Recall, this is a hemodynamically unstable patient, so they're hypotensive. The two sedative medications that I would pick are etomidate or ketamine, but at half the dose. So for etomidate, I would use that half a dose of 0.3 milligrams per kg. The ketamine, I would use 0.5 milligrams per kg. You want to remember this patient could get hypotensive even after you intubate, and they're already hemodynamically unstable. In terms of your paralytic, I would go for rocuronium and use it at a higher dose of about 1.5 milligrams per kg. The reason for this is rocuronium is going to act like Reglan in the sense that it's also going to increase the lower esophageal sphincter tone, preventing further regurgitation. So why not? So you're getting your induction agents, cardiac stable agents on board to help you intubate. At this point, you're also going to get your intubation material for this patient, which was spoken about in depth earlier by many people, but specifically having the video laryngoscope on hand. I would go for this immediately because you want to see what's going on and have everyone around you that's going to be helping you see what's going on as well. You always want to prepare for anything that may go wrong, so have direct as well, but make sure to have video beside you and make sure it's working. The other thing is your respiratory therapist will get the BVM at the bedside. This is the one time I want you to not use the BVM. This is because when you try to bag the patient before you intubate, it's going to cause gastric insufflation, which is going to induce vomiting in this patient by distending the stomach. So if you do have to use it for any reason, you're going to do it gently and slowly at 6 to 10 breaths per minute, if at all. But remember, this is why that pre-oxygenation is so important. This is why I want you to do the bed up, head elevated position at 30 degrees to avoid this at all. All right, now you're ready to intubate the patient. Make sure you have suction catheters at the bedside because these next 3 steps are going to have to involve this because the patient's vomiting blood. Imagine yourself in each scenario and then ask yourself which one you'd use. The first one is pretty straightforward. You have 2 suction catheters set up at the bedside, and you're going to need 2 assistants for this. Self-explanatory in the sense that you'd be using your video laryngoscope. Remember, you want them to see what you're seeing. Your 2 assistants are each going to have a suction catheter in their hand. They're going to come from the corners of the mouth while you're trying to intubate, continuously suctioning all that blood so that you get a good view and hopefully have a view of your airway to intubate. What happens if you don't have 2 assistants? Because remember, this is a hectic day. You're with that cloud, big black cloud attending, and everything is mayhem. Or you don't have 2 suction catheters at the bedside ready to go. Even more so, what happens if the airway is so small that you feel like you can't fit 2 suction catheters and your video, and it just seems like this isn't working? This is when I would consider doing the salad approach. Not the salad, obviously, but suction-assisted laryngoscopy airway decontamination, which was coined by Jim DeCanto and his colleagues. I'm going to play a video, but before we do this, again, envision yourself in this scenario. I'm going to take you step by step and picture what you would be doing. So you have your video laryngoscope in one hand, your suction catheter. Remember, this is your DeCanto suction catheter, so that rigid large bore suction catheter in your right. As you're looking at the airway and seeing all this blood, you're coming in from the right side with your suction catheter. You're suctioning the hypopharynx, you're going into the proximal esophagus, you're removing all that blood, and you start to get a good view of your trachea, your vocal cords. You then are going to move from the right side and pin the suction catheter to the left with your blade, securing it in place so that it continuously suctions all the blood, allowing you to get a good view of your airway so that you could intubate. All right, let's play this video. Coming in from the right side, suctioning, getting a better view. Now seeing your airway, vocal cords, hopefully. Gonna move to the left side, pin it with your blade in place, pass your bougie, and then you can successfully intubate your patient. Simple enough, right? But what happens again? You feel like the airway is just too small and you're not fitting that suction catheter well, or you can't pin it, or there's just so much emesis, so much blood obscuring your view, and you don't think this is going to work for you. This is when I'd say use the take the shot approach. So again, let's go through this and then we'll play the video. Same idea, you're using your video, you're coming in from the right side, you're suctioning, but now you get a good view of your vocal cords, your trachea. Instead of going to the left side with that suction catheter, you're actually going to place that large bore suction catheter in the trachea at the proximal portion, remove the top of the suction catheter, pass your bougie through it like a Salinger technique, which is exactly what this is. Then remove the suction catheter, bougie in place, your airway secured. You could either leave the suction catheter aside if you think it could fit, pin it to the left side to allow continuous suctioning, and successfully intubate your patient. All right, let's take a look at this. Coming in from the right side, your suction, get a good view of your airway, remove the top portion of that suction catheter, grab your bougie, Salinger technique, pass it through the suction catheter. You're now going to remove that suction catheter. In this case, he actually reattaches it, pins it to the left side, like you did with the salad approach, allowing continuous suctioning of your proximal esophagus, grabbing your ET tube, placing it over your bougie, and successfully intubating. Easy enough, right? You have 3 different ways to successfully intubate this patient, 3 ways that I know you could master. But what happens if you do one approach and you find it's not working for you and you have to change to a different approach and the patient starts desatting? Now you want to use your BVM. You need to get the O2 sats up. This is when I'd say grab your LMA because it's going to reduce your gastric insufflation, reduce distension of the stomach as it sits on the glottis, and bag gently and slowly. In addition, as mentioned by Ruben earlier, you could use those fancy LMAs that actually allow you to intubate through the LMA. So the iGel or the fast track LMAs, if your facility has it. Your facility may not have it, but if you do, you could place it at this point and intubate through the LMA, use your fiber optics, or even the flexible endoscopy and go to that if you have that. That might be the new approach to doing things with these GI bleeders. The last thing I want to mention is you could add a meconium aspirator actually to your ET tube and suction as you intubate, which allows you to have another form of suctioning in addition to the other suctioning that's taking place. This may soil your ET tube, but you could always replace it later. All right, so we went over a couple of things, but I just want to recap really quickly. Get prokinetics on board early, they may help, so why not give it to them? You also want to remember to resuscitate before you intubate. Give blood, give your pressors on board after you intubate. NG tube, as well as the bed up head elevated position for proper pre-oxygenation, as well as your medication induction agent. So your sedative at a lower dose, your rocuronium at a higher dose that increases your lower esophageal sphincter tone. You also want to remember to try to avoid using the BVM if at all. Again, bed up, head elevated position to help you pre-oxygenate well as making sure to use video with your suction catheter set up to use one of those 3 approaches, either the 2 assistant suction catheter approach, the salad approach, or basically the Salinger technique, the take the shot approach, having your bougie and your LMA on board as well as backup. You would have successfully intubated your first mafia patient at Staten Island and your GI bleeder, leaving it completely spotless and being that boss I know all of you could be as we started in the beginning. Thank you.
Dr. Hassan, thank you so much. That was fantastic. Really great tips. I love the idea of using the Salinger technique through the bougie, through the suction catheter. That's great. I'm going to definitely practice with that. I have one question for you from the chat, which says from Stacy Frisch. She asks, how do you use the suction connected to your ET tube with a stylet, or do you just forego the stylet when you're going to try and do that?
So there's actually a whole big discussion on this. Typically you're not going to have the stylet with this if you attach a meconium aspirator to the ET tube to intubate. However, some people have devised these little tricks to try to do this. I could actually send the link to you if you'd like in the chat, but typically you're going to eliminate using the stylet for the most part if you do attach a meconium aspirator to the ET tube, which makes it a little difficult, which is why this would not be my first approach.
Excellent. Probably one of the reasons maybe that our anesthesiology colleagues make us practice intubating without a stylet every now and then in the operating room, right?
Exactly.
Thank you very much, Dr. Hassan. Last but not least, it is my pleasure to introduce Dr. Brian Gilberti. He's Assistant Residency Director at NYU and a member of the ALLNYC Board of Directors, where he is affectionately known as our tech wizard. And he is the reason that we have all been able to successfully transition our in-person conferences to the Zoom platform. So we owe him a debt of gratitude for that. So without any further ado, take it away, Dr. Gilberti.
Thank you, Jenny. I think it's a dubious distinction to be the Zoom expert, but I'll take it. And today we've talked about Wu-Tang, we've talked about Peloton. I want to touch on coffee and just one of the ways in which it relates to critical care. And a little less abstract, I want to discuss how we can improve our practice by deciding to go out with the new and in with the old. And to do this, I'm going to talk about a couple ways in which the old way of doing something may be the better way to do it. And the newer way kind of just doesn't really compare. And so taking a step back, our profession is one that really strives to inch forward. And with that comes this desire to welcome advances with the hopes that this will help our practice. And inch by inch, we have morphed ourselves from snake oil salesmen to true doctors. However, sometimes this desire and being on the bleeding edge of medicine can be a double-edged sword. And by that, I mean, with this drive, we can have some missteps that can degrade our care. And history of medicine is replete with these. I encourage everybody to look into the very troubling history of amiodarone for the treatment of stable VTAC, how it wasn't the first medication to treat it, and it's not the best medication to treat it. Nonetheless, it gained favor with some. But I don't want to talk about antiarrhythmics. Today is Crit Care Day, so I want to discuss a couple meaty critical care topics. And in order to do this, I want to propose 3 examples in which our care could be improved if we went back to the older way of doing something, and specifically how we administer epinephrine in cardiac arrest, how we evaluate for fluid responsiveness in septic shock, and lastly, how we treat family members during resuscitations and CPR. So say what you will about epinephrine. This could be a whole separate talk, but I think that it has its own redeeming qualities. And I'm a very simple man. When I give epinephrine, I want it to be in the patient's heart. And when it comes to this, where we establish access plays a really big role here and deserves a little more of our time to discuss. And we've all done this. Compression's ongoing, we drill in an IO, we spray our medications, but is this the best way to run a code? Are we giving our patients their best shot at making it out of this? And multiple studies have observed some of the outcomes that we care about, like ROSC and neurologic outcomes, that these are better with IO versus IV. And don't be mistaken, these studies are severely flawed. They're very flawed. With selection bias, with the IO group being sicker than the IV group, all this can't be ignored. But it should call into question whether we prematurely have adopted IOs for this purpose. And just think about it. I'm sure a lot of us have had easy IO reps come to our program, talk about their product, but do they ever talk about these outcomes, anything that we really care about? And this is not the only study. It's not perfect, like I said, or definitive, but it should prompt us to scrutinize this and ask ourselves, is this a step in the right direction? And in order to take a look at why this might be problematic, we should see where we're giving these medications. And when we put it into the tibia IO, and unless we're chasing it with 20 cc's of fluid or a pressure bag, these medications can fester. And also we know in hemorrhagic shock that bone marrow blood flow decreased by 70 to 80%. So just think about what happens during cardiac arrest when sometimes the cardiac output is 20 to 30%. And lastly, when we put epinephrine into the bone marrow, that increases vascular resistance and reduces marrow flow. So a lot of things that could be problematic. And as is often the case, whenever we're confused or we're looking for some clarity and answers, we should look at our swine friends for some answers. And compared to femoral lines placed in pigs, only 53% of epinephrine given IO in the tibia makes it to the atrium, only half. So keep all this in mind. A crash fem may be the best way to get the right amount of the medications to the right spot, to the heart. Use an IO if there's no other access, but this should be a bridge and may not be adequate for access. So this is the first example where I suggest that we should take a step back and do it old school and maybe put in a crash fem during our resuscitations, our cardiac arrests. Next, I want to discuss monitoring fluid resuscitation. And here, we really do walk a tightrope between underdoing it and overdoing it. Underdoing it where we may under-resuscitate, whatever that means, or overdoing it where we can overload the patient, pulmonary edema, in rare situations lead to compartment syndrome. So we really walk the line here with these patients in septic shock when we're giving fluids. And ultrasound has been proposed as a way of monitoring fluid responsiveness by evaluating the diameter of the IVC and looking at respiratory variation. And from that, we're able to come up with the Cavill index. And that's what's been studied extensively for this purpose. And there's a lot of heterogeneity here, a lot. And one thing that may be constant is that maybe we prematurely adopted and have had confidence in POCUS for this application. Now, I know we're all fearing the POCUS gods, and I want to be clear that I'm not anti-POCUS. But for this application, it may not be as fruitful as we'd hoped. But it's very confusing. What are we comparing it to, right? What's a gold standard? What are we looking at for comparison? Cardiac output, stroke volume, VTI. These are a couple of attempts, but in a way, we're kind of flying blind. And until recently, like last month recently, we got a better idea of how blind we have been with this meta-analysis that suggests that maybe it's not as good as we'd hoped. By the numbers, TT of the IVC to predict fluid responsiveness had a sensitivity of 74%, specificity of 83%, and an area under the curve of 0.68. So really not that good. So we're left by asking ourselves, well, what are we left with? I'm not going to say lactate because we're going to get it and we're going to get it again. But also here's another place where it may be better to keep it old school, or at least dedicate a little more time to the old school methods. So MAP, urinary output, heart rate, respiratory rate, listening for rows on exam, how they look, their mental status. All these things put together, like Dr. Wilcox said, will help point us in one direction. They're going to be individual data points that we have to all put together. And lastly, and the most important point that I want to make in this segment is how we approach goodbyes in the emergency department. And it goes without saying that we deal with some of the most impactful moments in patients' lives. And with that comes a chance to dampen the echoes of grief for the rest of their family members' lives. So what we do in these minutes really do matter. Here's Lincoln on his deathbed, just to give you an idea what death used to look like. And yeah, we're not all on a stage. We're not all going to have this many people at our bedside when it's time. But it's just to give you an impression that you used to live with loved ones by your side and die with loved ones by your side. And it really entered into the sphere of debate in the 80s with this paper in 1986 published in the Annals. And I want you guys to look at the title of this paper, that family participation in resuscitation was an option, as if this were something novel to have family in the room during a resuscitation. And if you look at this paper, there's some really sad testimonials in it that highlights the fact that these are moments that can't be erased. And since then, the issues come more into focus, with the first high quality data emerging in 2013 with this prospective cluster randomized trial. And yeah, it's not apples to apples, orange to oranges, but family presence during CPR, which is what they looked at. And they also looked at if that had an effect, an impact on PTSD related symptoms 90 days out. And what they found was yes, it did. When they called these family members 90 days afterwards, they saw that they had significantly less PTSD-related symptoms, anxiety, and depression. And all these bonds between family members are pregnant with meaning. First kiss, watching your son's first steps, tucking them in at night, walking down the aisle. All these relationships have countless layers of meaning, emotions, and memories that are sacred and indelible. So who are we or administrators to say that, well, only one member of the family can come in when somebody's sick? And I wish I could say that this is current practice to offer family into the room. And I think that that was generally the case, but COVID has made us take a step in the wrong direction, in my opinion, by restricting who we allow at the bedside. And sadly, these restrictions still linger in most places with just one guest being allowed in. And we have to acknowledge that these decisions that are made very far removed from the bedside and far removed from the hearts that beat for the ones that stop. But now that we in healthcare have access to vaccines and a better understanding of this illness, I encourage us to go back to how we used to do it and how we used to treat our sick patients and their family members by allowing their family members in, and not just one member to be at the bedside, to hold their hand, to witness, to say goodbye, to embrace each other in grief, and to inch closer to closure. And if that goes against the rules, then we got to break them. We got to rip it up and do what matters, do what's right. So deep breath, let's do a recap here, how we can improve our care for the critically ill patient. First, access is access, but not all access is the same. And when you run a code, maybe a crash FEM will be better than a tibial IO. In fluid resuscitation and septic shock, one of the most basic aims still eludes us, and looking at the IVC may not be as fruitful as we had hoped. Looking at the more traditional measures of responsiveness may be better. And finally, the common denominator of what we do in medicine, in the ER, when we come to work, is to reduce suffering in the world, whether it's through our patients, through their loved ones, through their family members, and they won't get these moments back. So if people are critically ill, don't let them be critically ill alone. And if it's their time, let their family, not just one member, be there by their side so that they're not alone. And through this, we can take a step forward by taking a step back. Thank you.
Wow, what a thoughtful and meaningful and poignant end to our conference today. It's so true. What is old is new again, and our patients and their families, they need us to be present for them, and the patients, the sick and dying patients, need their families to be present for them. That was so meaningful. Thank you so much, Brian. And with that, everybody, I am so grateful that you joined us for this conference today. We had such a fabulous time sharing our speakers and holding company with you. We miss you, and we so look forward to the next time we're able to all be together, which I feel so hopeful that it's going to be sooner rather than later. We would be remiss if we didn't spend a second to pay appropriate thanks to Dr. Duncan Grossman, who not only provided 2 sensational curbside events, but he also was part of the production crew of today's conference. Dr. Brian Gilberti, who just gave us that really meaningful talk and is the tech wizard in the group. Dr. Eric Steinberg, one of the board members and group organizers. Brian Gilberti is also a board member, but Dr. Steinberg, also fabulous talk and part of the production crew. Dr. Jenny Beck-Esme, being excellent as she always is, and Dr. Kestel Riopel for our graphic design. Thanks so much to the ALLNYC EM Board of Directors for providing cutting edge, collaborative education. And I truly am grateful for you for your mentorship. And with that, I say, due to popular demand, here is a copy of today's playlist. And with that, I leave you. The playlist is coming back, you don't worry. Thank you so much for joining us. Thank you.
residential district. Presidential chipped out, Canary Rock sizzling. Mary Hot, Pop Pris, shorty got this. Fly angel, my dreams of a queen came true. In this land that's dark, if you my man and you my heart, I blast for you. Need bail, put up the cash for you. Girls who mad low, you die for you. Leave them if they acted too fly for you. All up in your mix, then it's somebody else six. Quick to put your name in some murder one shit. I'm not the one cheating on you or beating on you. Cause I'm laid back, you thought that I was sleeping on you. Real love make a ill thug feel bug. Now I've analyzed, are you trustworthy by the looks in your eyes? Stay with me, be my dog like Dollar and Richie. She convinced me, all we really need is love strictly.
You know love is all we need to make everything complete. I wanna be happy, you can be happy, you wanna be happy. You and me are strong and one, and I'm on the top and down. If we can love everybody. Love is all we need. All we need, yeah.
One love, one life. Live on, stay strong. Live your life, girl.
Everybody needs love.
Mary.
Now I like dollars, I like diamonds, I like stunning, I like shining, I like $1 million deals. Where's my pen? Bitch, I'm signing. I like those Balenciagas, the ones that look like socks. I like going to the Tula. I put rocks all in my watch. I like texts from my exes when they want a second chance. I like proving wrong. I do what they say I can't. They call me Cardi, banging body, spicy mommy, hot tamale, hotter than a Somali. Virgo, Ferrari, hop up the stoop, jump in the coupe, big dip on top of the roof, flexing on as hard as I can, eating halal, driving a lamb. So that bitch, I'm sorry though, got my coins like Mario. Yeah, they call me Cardi B, I run this shit like cardio. I'm in district in the chain. Certified, you know I'm gang. Drop the top and blow the brand. Oh, he's so handsome, what's his name? I need the dollars. Beat it up like piñatas. Tell the jobs to close the curtains. Bad chicks make you nervous.
Chambean, pero no jalan. Tú compras todas las Jordan, a mí me las regalan. I spend in the club, what you have in the bank. This is the new religion bank, el latino gang. Yeah, trato de hacer dieta, pero es que en el closet tengo mucha grasa. Ya mudé la Gucci pa' dentro de casa, yeah. A ti no te conocen ni en plaza. El diablo me llama, pero Jesucristo me abraza. Guerrero como Eddie, que viva la raza, yeah. Me gustan boricua, me gustan cubana. Me gusta el acento de la colombiana. Como me ve el culo la dominicana. Lo rico que me chinga la venezolana. Andamos activos, perico, pim, pim. Billetes de 100 en el maletín. Que retumbe el bajo y Valentín, yeah. Aquí prohibido amar, dile charitín. Que per pico le tengo claritín. Yo llego a la disco y se forma el motín.
Diamond District in the chain. Certified, you know I'm gang. Drop the top and blow the brand.